everyone. Thank you for joining us for our live MDA Engaged Pediatric Neuromuscular Care Seminar. My name is Kristen Brunk, and I'm a care specialist at MDA. We appreciate you joining us, and we are glad to be able to share this important seminar with you. I want to thank all of our supporters at Amicus Therapeutics, as their support is greatly appreciated. We believe in the power of bringing our community together for the opportunities to learn from specialists and having opportunities to connect with others. This event is part of a larger MDA Engage series with disease-specific symposia, community education seminars, which we are doing today, and community webinars as well. Here's the schedule of our upcoming community education seminars and webinars we will be hosting for the remainder of the year. The seminars are day-long educational seminars providing individuals and families with knowledge and resources around neuromuscular disease. Information is shared by experts in the field on a variety of topics related to care, resources, and research. I hope you take part in these coming up. Here is the agenda I have for today. As you can see, we have a busy day filled with wonderful speakers. I just have a few housekeeping items to go over before we begin today. We are recording today's event, and we will be posting it to the mda.org website for an on-demand viewing in a few weeks. For those of you joining the event live, please know that all phone lines have been muted. We will be having a Q&A session at the end of each presentation, so please utilize the Q&A icon to type in your questions. If you hover over the bottom of your screen, a tray of icons will appear. Click on the Q&A icon to open the feature and enter your question to host. You do not need to wait until the presentation is over before submitting your questions. Feel free to use the chat feature during this seminar if you have comments. Make sure you click on All Panelists and Attendees when you type in your comment. You will notice on the agenda there are small breaks in between some of the speakers. Please feel free to stay connected to the live broadcast during these times, but this will also allow you time to grab some water or a bite to eat. This is also the time when I will be checking audio for the next presenter, so you will be hearing us talking. And finally, we will be sending out a brief survey afterwards, and we would like to receive your feedback on what you have heard today. We want to make sure we're discussing topics that are of interest, and we use your feedback as a way to improve future educational events. I would now like to introduce our first speaker, Dr. Matthew Harmelink. Dr. Harmelink is an assistant professor of pediatric neurology at the Medical College of Wisconsin. He received his medical degree from the Medical College of Wisconsin and specializes in pediatrics, and he will be presenting on new research and clinical trials in the pediatric neuromuscular space. Thank you so much for joining us today, Dr. Harmelink, and I will hand it over to you.
Thank you for having me. I'm just going to quickly pull up my slides for us. We will begin. So I was asked to talk about new research and clinical trials today, and that's in pediatrics. That's a pretty big topic. So first off, the disclaimer is this is a huge topic. There's a lot of interventional trials, there's a lot of local studies. I will not be able to talk about obviously everything that's new. We'll focus on trends and some larger studies that have coming out. Maybe give a little bit of my views on some certain things, and certainly you may find multiple views on things. And I probably will end up with more questions than answers. But that's why we do research, right? We don't have the answers yet. We want to know more. Here are my disclosures. I do some consulting ad boards, things like that for different groups. So when we talk about clinical trials, and especially when we're talking with either primary care doctors who are asking about possible patients, or even with families themselves, there's a couple of questions we want to start asking. Families should be asking themselves. First off is, what is the target goal of the treatment? What does actually the treatment do? I've color-coded these by groups, but then secondary is how good is the supporting data? What is needed to get into the trial or the research protocol? And what obviously are the risks and procedures? Beyond that, there's more questions though. There's this, could this exclude me for something in the future? Right? If I do this trial, will it not allow me in something that might be coming down the road that I'm interested in? Or maybe even something that is more pertinent to my disease process. There's these very personal questions that are, if the data is positive from a trial, when could the drug be approved? How long will that take? How will that affect me and my family? Would we rather wait for it to be approved or not? For progressive diseases, again, for our kids, what's the time frame that they might qualify for? Are they going to get too far along in the disease process if we wait versus are they not unfortunately in some trials, not far enough along right now. And then this is the golden question is what might be approved and where trials started while my child's in this trial, right? If you're in a study that you might be interesting, but your whole heart isn't into, which I would always recommend against, and you're waiting for something to come out, could there be something that you're going to be missing out on? Now, when we talk about target questions, I look at this sort of as different pieces. So really, where is the treatment that we're talking about in the research going to be affecting? And now there are non-interventional trials that are looking at natural history studies or more database studies that are a little bit different. But if our target is, some sort of intervention, the first question is it symptom-based? So this could be looking at how does BiPAP function, wheelchair activity. It could be non-disease activity. So for example, in many of our diseases that have cardiac involvement, many of our cardiac meds don't actually address the actual genetic problem in a genetic disease, but may help by affecting things downstream, or just like the myostatin inhibitors, which sort of makes muscles bigger in theory, is this research just in general trying to make us stronger? Are they protein-based? So for example, Duchenne's steroids or enzyme replacement therapy in Pompe's, which again is still helping with the problem, but not fixing it permanently. Are we trying to do something that's more RNA-based, like exon skipping and Duchenne's and nusinersen, where we're actually trying to change how the DNA is turned into RNA? Or, and this is obviously a hot topic, the DNA-based, whether it's gene replacement therapy for the microdystrophy and Zolgensma for Duchenne's and spinal muscular atrophy, or even down the road where we have gene editing and CRISPR and those type of things. I will excuse my use of Zolgensma. I'm not going to use a generic name today because it is just a mouthful in terms of what I'm saying. So you'll excuse my use of that branding name. I apologize. As we break down these trials more, the red is really what the PIs only know in the trials and maybe can't share details. There's sometimes this data that is unreleasable that we may know about. But the question is, how good is the supporting data? Is it animal data? Is it phase 1 or 2 data? Is there similar platforms or drugs that have been used elsewhere, or even mechanisms that are just slightly changed based off the actual genetic change, like in exon skipping, for example? What's needed to get in? And this isn't just a criteria of age and activity level. You have to be on steroids for Duchenne's or not be on certain medications for other drugs. But what's the distance to get to the trial, and how quickly do we think this is going to fill up? Is there a reasonable expectation that we'll be able to be screened to see if we can get enrolled? And then of course, what are the risks and procedures? Some of these can just be from the drug, but it's also things like our, drugs or trials that may have to have multiple pokes if a child just hates that, to put them through that psychological stress of, weekly pokes for IV infusions or IV blood draws may not be the right trial for a family. From the family's view, and really what I always ask the families is, what might this exclude me from the future? Is there something, and I put in quotes, better coming out, right? Is there something that fits the patient better in terms of what they're looking for, both from a medical perspective, but also just a psychosociological perspective? Maybe there's something that has some better data. Maybe there's something like procedures for more. 2 drugs or 2 trials look fairly promising the same, but one doesn't have a muscle biopsy and you're very averse to any type of procedure. That might be something better for you there. Or something just better access to care. It's very unfortunate that unfortunately not every MDA center is able to do every trial. And so again, if you have to do weekly infusions and you want to be in a trial 7 hours away, that's a tough strain on families and on everyone to get there. Of course, there's a question, if the data is positive, when might the drug be approved? And can we wait for approval? Now, there's good things about that, right? Sometimes trials and research have more things that we have to do, more activities, just because we want to monitor with more data is better. But on the other hand, you might get access to drug. It might be a double-blind placebo where you may not know if you're getting drug or not, and that might affect your approach to it as well. And then if you wait, will your child be able to be approved? For progressive diseases, this question is, what's the time frame they might qualify, both medically, and then unfortunately, not in our day and age, we have insurance issues, especially in the US, where they may or may not approve it based on certain criteria. And so certainly there are trials where maybe you can get in and get the drug earlier. Now, the purpose of research, of course, is always to advance the scientific field. That is the goal, and to be safe while we do that. However, especially in the rare disease world, oftentimes research and clinical care sort of does mesh a little bit in terms of access of care, especially. And so that is something that we have to think about outside of the traditional view of research just for science. And then the golden question. while I'm in this trial, what might be approved, what trials might be started, what, what's the field looking like? But I don't think anybody can ever guess. But my big push is if families are thinking this, that they might want to drop out, because I have heard of this happening. Please don't get into a trial you're not going to finish. It affects the data of the trial. It's a lot of work to get someone in from the research side, from the company side, from the pharmaceutical trial, and certainly from the PI side locally. To drop out really sort of makes it very difficult, and especially if we have too much of a dropout, we may not have power to even see if it's efficacious. But there are this sort of desperation sometimes we see to get into anything. And then I have had families I've talked to who regret getting into certain trials because now they feel obligated when something else they would prefer to do is involved, or even procedures they don't really want to be part of, but they feel like they need to do something. So a lot of questions and as we go forward, but these are the questions I like to think about and talk with our families when they come to clinic. But the question was asked of me to present on is new and current research. And so the new part really got me because there's so much coming out. And so I said, well, why don't we approach this like a research trial, right? So I went to clinicaltrials.gov to look at what is out there nationally published. And we pulled up 1,406 trials listed for pediatric neuromuscular research diseases. And if we narrowed that a little bit, we came down to 266 are actively recruiting. So a lot that's out there is listed, but not actively recruiting, either in pre-recruiting stages or has been finished already. Of those, I said, well, new, right, would be the last maybe year and a half, 106 trials, which is still too large a group to go through in this short time frame. And if we said just since the beginning of this year, we had 47 trials. So I said, well, what has been started in the last year? What can we talk about? Now, I'm not an expert on every trial. Some of these drugs I know a little bit better than others, but wanted to sort of bring up what is out there in the field and hopefully use this as also a trend in what has been coming out and where research is going. Of those 47 trials, 24 were relevant. So we look at some of the non-relevant trials for our talk, right? Some were about polio vaccines or gabapentin for treating chemotherapy effects or some gynecologic cancers and peripheral neuropathies. Probably not what MDA is looking for. So I excluded those type of trials necessarily. And here's what we have for the list. And I leave this up there so if someone wants to go back later when this is posted and see sort of what trials I found that opened up in the last year, they can actually get this full list. This is actually copy and pasted from clinicaltrials.gov. And here's our second part of that too. So there we go. Of that, I'm not going to talk about all 26 because there are some large areas I think that I want to sort of focus on for the trend pieces. So more to come. So I started off with thinking, okay, let's start off with that therapy target. Like, what is our target? And if we look at symptomatic target, there's some interesting trials that are very localized. But as I look through this list, I go, this is an interesting thing. I'm going to look for the data. First one is actually a wheelchair positioning in neuromuscular disease trial coming out of France. There's only 2 sites. And they're looking for wheelchair posture pain in a wheelchair and the effectiveness of the recommended equipment. Now, it's an interesting thing because you'd think at this point we have all this data, but there's a lot of gaps in our knowledge base that are being overtly researched and have a lot of data coming out. Neurocognitive outcomes, for example, is not as well researched as we probably would. And sometimes we take for granted things like wheelchair positioning. So this is a symptomatic interventional trial, but it's really looking at a target that's not overly aggressive with the patients. So something to look forward to. And as you see, if you go to clinical trials, hopefully by next year in December, we'll have some data and we can talk about maybe we can modify our treatment plan. On the same note as sort of other things that are interesting coming out is there's this determination of awareness and associated factors with development of neuromuscular scoliosis. So it's a bigger trial coming out of Turkey where they're trying to look at, what are the risk factors for scoliosis? Again, bone health, back pain, scoliosis surgery does vary quite a bit between the diseases, but also between the centers and how we manage it. The more data we can get, I think, in terms of preventative care, especially, which is one of these things that will come out of here to help for. The only problem I think for here is this is going to be a very diverse population because it's all neuromuscular disease and cerebral palsy, which I think will make it a little bit harder. Symptomatic in observational study. So again, we'll see how the data comes out, but interesting to see. And again, more things that we'll be able to hopefully guide care better. Now, I'm going to switch a little bit to a few disease processes. And the first one we're going to talk about is Duchenne muscular dystrophy. I know a lot of people who are listening to this probably are aware of the disease, and you can certainly go to the MDA webpage for more information. As a brief overview, this is a genetic disorder that predominantly affects boys. You have progressive muscle degeneration and weakness due to alterations in a protein called dystrophin. And typically the onset is in early childhood between ages 2 and 3, but there is some data we can actually have some subtle features earlier, primarily affects boys, and in rare cases can affect girls because it is on the X chromosome. In Europe and North America, the prevalence is about 6 per 100,000 individuals. So not a uncommon rare disease. If we look at therapies, when we think about genetic therapies, you have to remember that all of our body has chromosomes, 46, 23 from mom, 23 from dad, 46 for most of us. On each chromosome is hundreds and hundreds of thousands of genes. And each gene is made up of portions that become protein and portions that are regulatory, and they're not all the same. Their exons become the protein and introns stay in, and they sort of, as you can see here, this is a piece of sort of the middle of the dystrophin, exon 49, and there's a little bit of space of stuff that's not protein, exon 50 become protein, and how they match up and line up with the coding isn't always that a whole exon just ends with all that, the amino acids, the parts of the protein. They sort of have to be translated to RNA, which fits together, taking out the introns, and then eventually become the protein. So the problem is, well, we can have a mutation. So in a normal case, right, we have this gene, becomes RNA, becomes a protein dystrophin, working well, that's for a normal healthy person. And someone who might have Duchenne's, for example, they might be missing an exon. Let's say exon 50 gets deleted. So 49 doesn't fit in nicely to 51. And so we make maybe a little dystrophin or dysfunctional dystrophin gets destroyed. Typically it's under even like 1% dystrophin. And at that point, we really have the disease process. And I'll talk about this as we go down a little bit. But the idea is, well, there's multiple ways we can do this. Can we affect the RNA and maybe just skip over? Or maybe we can actually reframe it by changing some of the DNA itself. We get a shortened functional dystrophin, but maybe some other effects. So one of the trials that actually is doing that opened up this year is the WAVE in 531 is looking at 15 patients in ascending doses of drug. And it's a phase 1b/2a study. So early on looking at increasing doses and trying to figure out what is the dose relationship for the drug. Just started off just a month or two ago and looking through sort of next year. This is a drug that's going to be affecting how our RNA and eventually downstream our protein looks, and it's an interventional trial. Now, one of the things as we look at research, and especially for families, we always want to look at, again, as we start comparing things, both what are the mechanisms, what's the data. We have to be careful, though, about saying, well, a single company maybe had a drug before that didn't work, because part of research is making changes, right? So we see what works. If it doesn't work well, we make a change, and you'll see as I do that, as I talk, we'll go through that some more. I bring this up because WAVE actually had a exon 51 skipping drug. Now this is the one I was talking about is exon 53, that the phase 1 data did not show changes in baseline, and so they did not move on with that going forward. However, it sounds like looking at through their website information that there's a little bit of a difference in terms of what these drugs are, so it might be efficacious. And that's important to know rather than writing something off. Now, I'm not knocking away pharmaceuticals. Again, actually, we were a site for the exon 51 skipping drugs, so I think the science might be there. The question is really going to be what is different in their platform or their drug then versus now if you want to get into the study. And that's a great question to ask the PIs if you're interested in these type of studies is, have there been trials before? What did it look like? All that data. And then the other question for families is how do we compare this exon 53 skipping drug to what might be actually on the market already, right? Commercial, Golodirsen, Pitolisant by 2 different companies. How would this be better? How would this be more intensive? And again, I will always encourage families to do research because I think the more data we have, this is the time where greed is good, to quote the 90s movie, but the more data is better. But it is for the families, you have to make that determination of sort of which way we want to go. However, it's nice that we're having multiple drugs for some of the same areas come on the field. If we switch over to sort of a different type of mutation for Duchenne, so atalurin is a drug that's been studied for quite a while. Excuse me, for quite a while. They're actually doing a trial for kids between 6 and 2 years of age, looking at nonsense mutations. Atalurin is sort of a non-specific drug for these nonsense mutations, so a change where normally we have, as we go through our exons again in our base pairs, there are combinations of base pairs that say start reading here, and there's combinations that say stop reading here. If, as we have a change in our DNA, if it says stop too early, obviously that is a bad thing. And atalurin sort of helps avoid that stop codon so we continue to read downstream. This study is actually a 24-week treatment and has at least 52 weeks of extension afterwards for safety and pharmacokinetics. So someone coming into this would be looking at a almost a year type study, maybe a lot longer with the screening. Very small participant pool though, so that's something a family should be aware of. This is an RNA interventional treatment, and it's actually showing sort of the mechanism I talked about before. So this is our polypeptide, and if we have this stop codon as we read through, we're going to say, hey, it's truncated and short. If we can have atalurin, we can read that and have a longer, more normal protein. It is also only one site in Atlanta, Georgia. So unless you want to travel there, that is one thing to be aware of. Now, the other part with adult learning we have to look up is, so not always is something not approved in the US or approved elsewhere. How regulators look at data may vary, and this can be frustrating for families as well. Adult learning, for example, was denied in the FDA, but approved in the EU. I've got the asterisks there because it was at one point conditionally approved. And this is actually from the initial, not this study, but previous studies here in the US data that was presented to the FDA. It's off their website, showing that there was some effect in sort of preserving this NSA functional score over time compared to the placebo. The question is it statistically significant and significant enough? And those are all where the approval process goes into play. So this is one of those cases where you have to weigh that data as well for a family coming into a trial, or even for a site looking to be part of the trial, to say, is this a study that is the right study for my child based off where they're at? Now, what's interesting is that these trials were typically older patients. So the shift to younger kiddos, I'm anticipating, I don't know, but my guess is we're looking at, can we intervene sooner? Can we see a bigger effect? Which, again, we've been seeing through many neuromuscular progressive diseases, SMA, with many of our treatments has shown that, and even some of the steroid data on Duchenne's is showing maybe if we start a little bit sooner, we can have some better effects going forward, though we don't have long-term data and years of data in those studies as of yet. So what about other sort of non-similar drugs? So there is a study of ASP0367. This is for male participants with Duchenne's, and it's looking at global safety, tolerability, and preliminary efficacy in a 24-week treatment period. And then it has this sort of double-blinded first half, and then you go into everybody gets it with two different doses. Astellas Pharmaceuticals is doing this in many sites throughout the US. It's a drug that actually affects mitochondrial energy usage, trying to shift more to fatty acid utilization to have increased energy, with the thought of maybe this can actually help with some of the muscle breakdown, things like that. Again, this would be sort of a non-specific to the dystrophin gene type trial. What's interesting is they're also using this drug for primary mitochondrial myopathies as well, because it's this non-specific type therapy. This is also interesting as we start talking about multiple drugs and multiple mechanisms, because one of the things you will see is that we don't have, even for our approved drugs, head-to-head trials. It's very difficult and expensive to run, as you can imagine. And because these drugs are coming out so quickly, with more data on them coming out, we're having to make these determinations really based off the data that we have. The other question that's going to come out is dual therapy combinations, things like that. But again, we don't have really a lot of data outside of just using corticosteroids, which most of these trials are requiring, unless it's a steroid-sparing trial. And that's something I think that's important for families to remember as we go forward too, as we start talking about, can we be on, outside of research, can we be on, for example, an exon skipping drug and something else? And those are individualized discussions that have to happen. If we look a little bit still with Duchenne's, but some other sort of things that are cool that are coming out when I was reading through these, one is this virtual reality glasses for multimodal physiotherapies in Duchenne's and Becker. So the idea is, can we use virtual reality glasses to increase the effectiveness for physiotherapy, and also looking, can this be tied a little bit into research and how we do that. Small group of participants just out of Spain, 11 people. Of note, if you look back at physiotherapy and virtual reality for the last 15, 20 years, there's been papers that are coming out in different areas for this outside of neuromuscular. So it's something that I think will be interesting as that technology is hitting mainstream. How do we incorporate that into our clinics and into our research? So hopefully next June, they're hoping to have this study completed. So in the next, typically I always think it's 6 months to a year before we start to hear data after that. But that means, we might be getting some more information there. If we go to other type of drugs, there is a study coming out of Poland looking at metoprolol, approved drug, on the treatment of standard of care for preventing cardiomyopathy in Duchenne's patients. I bring this up because some of the trials I've been mentioning so far are, year-long, 24 weeks, things like that. Now, those trials may affect if you want to do future research after. There are typically wash-up periods for those drugs if it's an interventional trial that way. This trial, on the other hand, is a long trial. It's a placebo interventional trial, so some kids get metoprolol, some do not. But it's a 5-year trial. It's 150 patients coming out of one site in Poland. The great things about this are we do get some great data comparing, efficacy. The only thing we have to be careful of is, if we look at single center trials, is other standards of care that may differ from the center you're in, or differ from what your child needs, may make this a little bit harder to interpret. But these are the types of data that I'm also excited for. Unfortunately, it will be at this point, 2026, 2027 till we're getting all the data. Hopefully there'll be some cut in points in between, because even in trials, we don't need to wait till the end of research to see all the data. Many times there's defined interim data releases that we can look at and interpret along the way. If we shift gears to spinal muscular atrophy a little bit, this is for those who aren't aware, degenerative autosomal recessive genetic disorder. So you have to have both copies affected. It affects the anterior horn cells of the motor neurons of the spinal cord. And here we can see, again, this is where the motor neurons would sit, as if we're sort of staring down someone's spine, and at each level there's motor neurons that then go up to the muscles here. It's recessive in that if a mom and a dad are both carriers, about a quarter of the patients will end up having the disease. There's a 25% chance for every child. So over time, it is one of the more common genetic disorders that affects children, and used to be one of the most fatal pediatric genetic disorders, but now with treatments, not necessarily. Patients will be born and have over time progressive wasting of voluntary muscles. Typically it's muscles proximal, so closer in the hips and the shoulders than distally. Legs get weaker than arms. You start getting tongue fasciculations as the nerves get irritable, lose your reflexes, and eventually have breathing problems with intercostal muscles. But as far as we know, patients have normal intellect and sensation, and they're often described as this bright-eyed, hypotonic, or floppy baby. Again, if we look at the genetics, it's interesting in that we have an SMN1 gene, which is the gene that is, if it's both copies are affected, you have the disease. And that there is an SMN2 next to it that has a teeny tiny little change. So there's, one little C in the thousands of letters that becomes a T. And so that's been one of the mechanisms some people have looked at, and some of the drugs that are FDA approved are out there is sort of saying, well, normally this SMN2 protein becomes unstable because that little change you can see goes 1, 2A, 2B, 3, 4, 5, 6, 8, whereas normal SMN protein has to have 7. It just does, that causes 7 not to be made in from the RNA to the protein. However, if we can change that a little bit, maybe we can make SMN make more functional protein. It's a function of 2 of our FDA approved drugs. So there are other treatments that are coming out. Now, this drug, OAV101, is actually approved. That's Zolgensma. It is approved already in the US for use in kids. Typically, it's younger children because of some dose-related effects with older kids. There is this international study going on, though, for 24 patients that's actually looking at a higher weight, because the question is, well, oftentimes when we do these type of research trials, we take from animal models, we bring into kids, we set some guidelines, but we don't always have the perfect dosing right off the bat, or we don't always have the perfect, highest weight, because you have to gauge where we don't want to go above and start causing effects. And so it is somewhat of a educated guess. And as we start refining things, we then look at safety measures more. Can we go a little bit higher in weight, and what are the outcomes? Can we go a little bit higher in the dose? Are there more side effects? And those are things that oftentimes come out after approvals in most cases of these type of pharmaceutical drugs. So this is a study that's going on, should be completing by August 2023. It will be interesting with this data because it could potentially open up older kids to possibly getting Zolgensma. So more to come. It is an open label study, so everybody is getting the drug. So interesting there. What is also interesting, though, is that just this spring, a model paper came out of mice, and it was looking at, well, if we give too much SMN protein, what happens? Because that's not something we've typically studied up until now. We've been worried about not having enough in humans. So they did, sort of as a quick summary, they gave mice gene replacement therapy and gave them too much, and they did find there are some toxic effects. Now, have no idea how this correlates to humans, have no idea if, what the dosing is relative to humans. More data is needed, but it is something that as we start talking about other trials and people talk about dual therapies, I think we need to be aware of and think about it. The problem with this, again, in research is this is one small study in a mouse model. So more to come, but be aware of that. If we start looking over to things like then, okay, what happens if we give, nusinersen? Now, this is a drug that actually helps with that little C to T change I was talking about. In this case, it's actually a study in France looking at some motor outcomes for patients treated, trying to see can we use this MFM32 study, looking as a standardized validation study. So the patients are getting treated only with nusinersen, so they're not using other patients, and about 60 kids will be enrolled in France. Versus, now I sort of mentioned the dual therapy in the mouse model. Well, what happens if we look at kids who have dual therapy? Now, these type of trials are really interesting for me and many of my colleagues in neuromuscular, because it is something that we need to know, right? If you get one drug, can you get another? What's the safety effect? What's the long term? Is it efficacious? What do we see? The hard part is designing those trials, because They can be very expensive in one case, or they're using more real world data, which can sometimes throw in some confounders when we try to take that to every patient. This is an interventional trial here in the US. There's actually multiple sites and a few international, about 60 patients. It's actually started at the beginning of the year, and it's only looking at patients who got Zolgensma and then get put on nusinersen because they think there's not a significant enough effect. And how much of effect will we actually get? Should we be doing dual therapy is really one of the questions. Now, the hard part is, as you can see, the completion date is going to be in 2024, which means we're only still having a couple years of data. We're not having the 20, 30 years of data that some people would say we want to see, but we're going to be starting to get these type of studies that coming out, which will then allow us to guide better, because I know, as many of us know, many centers treat patients very differently. Some are very pro dual therapy, some are very against dual therapy. I'll be honest with you, my bias tends to be a little bit more nervous until I see data. So that's what tends to be how I approach things. And then there's other discussions coming on and things that as we look forward in the next couple of years, hopefully we'll see things like we talked about Zolgensma. What if you give it after you're on nusinersen? What if you do risdiplam, another FDA-approved drug, after Zolgensma? What if you do nusinersen and risdiplam? And then all the combinations and things and variations there. There's also questions as you think of these trials are they looking at efficacy? Is it efficacious? And what is the goal? What are the patients coming in looking like? And how do they improve? What is the safety? And is the safety long-term or short-term? And these are all questions we'll have to follow. There is some databases I'll talk about in a bit that I think will help sort of drive this discussion some more. If we shift gears a little bit to another disease that's fairly common, myotonic dystrophy is a multi-system genetic disease. And it's unlike the others where it's a change in the gene and you tend to have not enough. In this case, there's a part of the gene repeats. And if we think of our DNA being sort of having two copies going together, if you get one area that gets too long, you can imagine how this part pairs up with this part pairs up with this, and suddenly you end up with this little hook here. And that extension and expansion repeat can cause misalignment and then can cause other protein problems downstream. In patients with myotonic dystrophy who have this with their genes, you can develop muscle weakness and cramping, heart rhythm defects, endocrine problems, cognitive problems, and eye abnormalities, amongst some other issues. Based off how long the repeat is, typically determines the earlier onset of symptoms. So there's an adult onset form, and there's also an onset form at birth. For congenital myotonic dystrophy, or those patients who are born very early, there is a drug that's currently in efficacy and safety trial data. 56 participants in sites across the US, UK, and Australia, where they're assigning this medication, which is supposed to downregulate that increased probable problem protein, and looking at some of the long-term effects. So it's a randomized double-blinded study. So people in the study will not know if they're getting the drug. They're either getting that or a placebo, and they're looking at kids and adolescents coming out. So again, interesting as we sort of pull out some of these other diseases, this little different type of mechanism of downregulating something rather than upregulating something. This is based off of the phase 1 study. So that the study they're doing is not a phase 1, it's beyond that. There's a phase 1 study. And I mentioned like, what does other data show? Well, there were 16 subjects, age 13 to 34 in the phase 1 study. They got 12 weeks of drug, and the pharmacokinetic, how the drug actually is metabolized and works in the body, and some of the clinical benefits seem to be favorable, which is why they proceeded on to the bigger study. So it seems like there's some promise to the drug. As I look at the studies prior, it's enough that I would say, yeah, that's reasonable for a patient interested to think about going in. Now, the protocols are not necessarily released outside of the PIs because that is confidential information for many of these pharmaceutical companies. It's a pharmaceutical trial, so you will have to reach out to the PI or to the company to figure out the exact details of that. That was the red questions that I was talking about. So I'm going to go off clinicaltrials.gov now as we get back to our sort of last 15 minutes of discussion, because there's a lot more studies going on. Some started before the new year. There's some areas of microdystrophin studies that are now starting to talk about recruitment. I want to talk about some highlights of things that I'm seeing coming out as we go forward. First off, I can't forget to mention natural history studies. Now, some of these are on clinicaltrials.gov, like the Pearson's natural history study, there's a limb-girdle trial as well. But there are things that are not always listed on clinicaltrials.gov, especially if you look at the rare genetic diseases. They may be local site studies, or especially, for example, I have a data bank I have that is for POMGNT1, neuromuscular dystrophy, a very small group of patients. For some of these type of studies, you have to find the patient networks, advocacy groups, and they can direct you if you're interested in being involved. I can't say enough how valuable these natural history studies are. We need the data, and we need more data. A lot of the data that we have had, 20, 30 years ago was focused very much on survival, muscle strength, breathing, maybe cardiac. then we sort of, but as we've gotten more treatments, now we have to also look at things like bone health, neurocognitive outcomes. And I was actually just giving on a panel a few weeks ago, we were talking about how we have a lack of data in Duchenne's, for example, for long-term neurocognitive outcomes of our guys, because the typical Duchenne boy before we had treatments was passing away early, and as life expectancy is starting to become longer and longer, we have to start thinking about how does this affect them getting jobs and having normal social situations and things like that. There's some of these actually built by organizations. So MDA has the Mover database. So if you are going to an MDA center and have of diseases, you may be asked to participate. That's really great because we can then pull data and look at longitudinal information. QSMA has a registry, PPMB has a Duchenne's registry. Now I understand that for some diseases, there are many registries, and it's hard to be in all these together. This is where we're going to talk with your site about which ones they're participating in and which ones they think, based off the data are good for you, but more to know. There's also pharmaceutical databases. For example, the Novartis Avexis has a SMA registry where they're looking at patients longitudinally as well. That has actually pulled out some interesting information on safety data, looking at Zolgensma things. For example, there was a paper that came out in the last year looking at a little bit of some kidney problems that can occur with Zolgensma that was not seen in the initial study to get it approved in the US because the N number may not have been big enough. As we get bigger and bigger amounts of patients, we can find that, maybe side effects that are incredibly rare, we start to notice. For rare diseases, having 100 patients in a study is amazing, but if your side effect is 1 in 1,000, you may not capture that data. So this is why these longitudinal follow-up studies are really important and encourage families to participate. Now, microdystrophin, I have to mention because obviously this is a hot topic, and if you follow the public press, if you follow the media, the scientific reports, I call it sort of an adventure movie because it's sort of you get good and bad, and you never quite know where we're going. There's a couple different companies that are doing these type of trials, but remember that the trials are ongoing and not all the data is public. So unless you're involved in the trial, you only get to see a certain percentage of what's coming out publicly released. For example, Salad had some early safety questions. That seems to be better. We'll see what efficacy shows. Sarepta had that data released a little while ago that said, well, maybe it wasn't as enthusiastic, but if you took the smaller subgroup of younger kids that had better outcomes, we'll see how that looks going forward. Pfizer had some patients with cardiac complications. Oh, but maybe that's a genetic subtype only. So if they change their protocol, we'll see if that can be avoided. Overall, my view is these type of therapies do have promise. The outcome data seems to be good. And as we move forward with things and start to redefine a little more some of the subtypes or subgroups that we're able to treat with different drugs, and I think that we're gonna get some good results is my guess. Now the questions I sometimes see from families and from other PCPs and providers are, well, can we compare the data? Not yet. For one thing, we don't have all the phase 2 data to compare, and there will be some variances between the trials that may make that hard to have perfect comparison. The good news is we have multiple therapies. Now, these are gene replacement therapies. They don't fix someone's DNA, but they are putting a shorter version of dystrophin back in the nucleus with the idea of, maybe the whole big dystrophin is ideal, but a shorter version may be better than what's being produced now. The good news is we have multiple studies that are competing, right? We're in a time and an era where we have people who are studying how to treat the same genetic disease in multiple ways. I know there are some frustration amongst families for the rare diseases or the rare mutations. This is non-mutation specific when it would get to clinical use. Obviously, the trials are avoiding some of the milder variants in many of these trials so that they have better data. But for those who have rare diseases that are not Duchenne's, I know there's some frustration about why can't we have those drugs. More to come on that. And then, of course, gene editing. Now, this has been talked about for a long, long time, but Vertex, Cure Rare Disease, Sarepta, they're all coming out with preclinical type data for Duchenne's for gene editing. This is CRISPR-Cas9 that people have talked about, where you can go and change the actual DNA and then sort of make it that it works better. So in neuromuscular diseases, as far as I've been able to find, it's all preclinical, but there is some non-neuromuscular diseases that are doing clinical human trials, and some of that data is encouraging. So we can't necessarily say that means neuromuscular data is going to be encouraging as well, but it does say, hey, no one has turned purple, no one has exploded, things look fairly good with those type of things, that type of administration. Hopefully this means that for our kiddos as well, this is going to be something that coming down the road is beneficial. I bring this slide back up only because the idea of, as we look at CRISPR editing, the idea is gene editing is actually changing it. So where we talk about exon skipping, where you would not have that 51 become part of your RNA. This is DNA, this is RNA, and you have a shortened functional protein. With the idea with CRISPR-Cas9 is, well, if 51 is there, we can actually just reframe it, right? So we take this back part out and cut it out, and we can have 49 then fit in there already. The ideal is that we're fixing the DNA here. So the question is, how often do we have to redose? Maybe not as much. Is this something that is maybe a one-time dosing? And again, more to come on that, because there's some big questions of, until we have the research on the longitudinal effectiveness, the 20, 30-year data, you can never be guaranteed. Now, I mentioned a little bit before about these ultra rare diseases, right? So you have a child who is the N of 1, or there's 4 kids in the world with that one gene change. Oh my gosh, we're never going to get to those kids. Not necessarily. In Lorem, I use this example. This is a nonprofit. They actually came out of Ionis, which helped develop nusinersen, and was worked with Biogen on it. Biogen is now the manufacturer of nusinersen for SMA. But they're actually looking at rare diseases, ends of 1 to 10 patients, and using antisense oligonucleotides, so that sort of skipping mechanism that I talked about in SMA. If a child is amenable, they're considering for that case. They're a nonprofit, so what you'd have to do for these type of organizations is typically your physician would reach out to them, send in a proposal with the genetics. They would want to look at, first off, is this something that they think is amenable? There might have to be some basic science studies that go on, and if it gets approved, then possibly can move forward. For those people who are interested in this, there was a medical paper that came out 1.5 years ago about a patient with a non-neuromuscular disease, Batten's disease, where this was sort of the therapy coming out. But more and more people are looking at this as well. So a lot of hope there as we move forward. And as people understand the mechanisms and the delivery models in more common diseases, it's easier to pull out that theory into the rare diseases. Now, there's also some place at academic centers or certain other organizations that maybe aren't as big publicized that do this as well. So again, for the rare diseases, this is where it's important for those families to get involved with the nonprofit group for their rare disease, and work with those groups on finding those options and opportunities, or getting involved in the natural history data to get the data to start moving towards that treatment therapy. So I do talk a little fast, and I apologize for that, but I know we may have some questions. So it's the overview of all this is, in the last year, it's been fascinating where we're going. A lot of stuff is coming out, a lot of trials are coming out, especially for the more common MDA covered diseases, but even for the other rare diseases, we're seeing a lot more therapies come out. And it's an accelerating process, which is also a fascinating thing. And I'm a young, as I said, assistant professor, and I've seen, when I started, there was nothing. In the last 7 years, we've had many drugs coming out, so much more to come. But sort of, this is sometimes how we all feel, I think, is sort of this goofiness of, we don't know what's going to happen as we try to answer these questions. So bear with your physician providers as we work through this with you. Thank you so much for having me. Any questions?
Thank you so much for that presentation, Dr. Harmelink. I would now like to open this webinar to our attendees for any questions that you may have for Dr. Harmelink. Like I had previously mentioned in the beginning of the webinar, if you hover over the bottom of your screen, you will see a Q&A bubble. So you can click on that bubble and type in your questions. So I'm just going to leave a minute or two for any questions to come in. All right, so I'm not seeing any questions right now, but I just wanted to give a reminder that this webinar is being recorded and will be posted on mda.org. So if you do watch it and you do have any questions, you can email mdaengage@mdausa.org. I would again like to thank our presenter for today, Dr. Harmelink. We sincerely appreciate your time and expertise and everything that you do for the neuromuscular community. So thank you so much.
Thank you. Have a good weekend.
Here is the updated agenda I have for the rest of the seminar today. I just have a few housekeeping reminders before going over everything before we continue. We are recording today's event, and we will be posting it to the mda.org website for an on-demand viewing in a few weeks. For those of you joining the event live, please know that all phone lines have been muted. We will be having a Q&A session at the end of each presentation, so please, again, feel free to utilize the Q&A icon to type in your questions. Alrighty, well, hello and welcome back to the MDA Engage Pediatric Care Seminar. I would now like to introduce our next speaker, Dr. John J. Parent. Dr. Parent currently serves as the Medical Director of Pediatric Cardiac Transplantation, Cardiomyopathy, and Advanced Heart Failure. He received his degree from Indiana University School of Medicine, where he also went on to do his pediatric residency and pediatric cardiology fellowship. During his pediatric cardiology fellowship, he obtained his Master's of Science in Clinical Research from Indiana University. Following his pediatric cardiology fellowship, he went on to do one additional year of training at Cincinnati Children's Hospital Medical Center in the areas of cardiomyopathy, cardiac transplant, advanced heart failure, and mechanical circulatory support. During his training in Cincinnati, he trained under many of the field experts in these areas. He is certified by the American Board of Pediatrics in pediatrics and pediatric cardiology. Dr. Parent has a particular interest in inherited forms of cardiomyopathy, including those associated with various muscular dystrophies. His research focuses on the genetics and treatment of cardiomyopathy, with a particular interest in left ventricular non-compaction cardiomyopathy. He has presented his research at regional, national, and international meetings. We are happy to have Dr. Parent present today. And with that, I will hand it over to you, Dr. Parent.
Thank you, Kristen. I appreciate it. Can you hear me well? Great. Let me just share my slides quickly here. Well, good. Again, thank you for the invitation to speak. I really like giving talks like this. I kind of think of this talk as a talk of what it would be like to be in clinic with a pediatric cardiologist in a neuromuscular clinic over the years of a patient. And so there's a lot of information here, but I try to hit the highlights on sort of all the subtopics. And one little caveat is a lot of this will be focused on Duchenne muscular dystrophy, but a lot of the philosophies and treatment strategies really extrapolate to all types of neuromuscular disease. And so I want everybody to sort of keep that scope as they sort of listen to this talk, that this can apply to really all sort of neuromuscular diseases. Just how we focus in from a cardiology perspective kind of determines on the specific type of neuromuscular disorder that the patient has. And so the name of my talk is Taking Care of the Heart with Neuromuscular Disease. I have no financial disclosures. I am a site primary investigator for 3 studies that do involve patients with muscular dystrophy, but I do not receive any sort of compensation for that. And so as cardiologists and people who take care of patients with neuromuscular disorders, we sort of break the heart down into 3 categories of how we're monitoring it. And I sort of think of the heart as function, meaning the squeeze of the heart, how well it sort of squeezes and pushes the blood out to the body. Relaxation, our fancy term we have for that is diastolic function, is the heart relaxing healthy so that it can refill with blood and so it can prepare itself for the next cycle to push the blood out. Another subcategory in the heart that's fairly unique to muscular dystrophy and is found in a few other types of heart disorders is scar tissue. So fibrosis or scar that can develop between the heart muscle cells can actually cause damage to the heart and cause clinical issues for the patient. And finally, arrhythmia, a term we use to say a patient's heart is going abnormally fast or abnormally slow and can cause issues. So if we break the heart down into sort of those 3 categories, sort of most of my talk will sort of focus on how we monitor each of these categories and how we can treat each of them if they become abnormal. And so I think a really important thing to sort of know, and again, this is just for Becker and Duchenne patients, this sort of graph, but there can be a similar graph for all types of neuromuscular disorders. But if you think, if you can see my cursor here, each one of these is sort of a cell of a heart muscle, and our heart is made up of billions of heart muscle cells. And so each one of these looks like this if you sort of cut it open and looked at it under a high power microscope. And if you look, the heart muscle is really made of various types of protein that have to work in sync through each heart cycle. So 60 to 180 time beats a minute. And so if one of those proteins become abnormal, you could imagine how the heart muscle might become abnormal and the heart function or rhythms could be abnormal over time. And so if you look here, the green sort of snake-like protein that's going through here is dystrophin, and that's the protein that's abnormal in patients with Duchenne muscular dystrophy. And the purpose of this protein, as best we understand it, is it anchors this heart muscle cell to sort of the glue between these billions and billions of heart muscle cells throughout the heart. And you can imagine if this protein is dysfunctional or we don't have enough of it, those heart muscle cells aren't anchored to that glue and over time might become weakened, or they might not communicate from cell to cell electrically, and so we can develop electrical problems. One way to look at heart involvement in Duchenne's is really just the squeeze of the heart, although that's not the only focus. But if you look at how prevalent is heart involvement in patients with Duchenne muscular dystrophy, and this is over the years. So if you take a patient with Duchenne muscular dystrophy who's less than 5 years of age, very rare that you're going to see any heart involvement. And as they get older and older, as you can imagine, and time develops more problems with the heart, it becomes as prevalent of 75 to 90% of patients over the age of 20 years are going to have heart systolic dysfunction, and probably even more with other types of heart dysfunction. And so as we educate families in the clinic, we almost say there's an expectation at some point your heart is likely going to see some involvement, and we need to monitor for that so that when we find involvement, or if we can find ways to prevent involvement, we can act on that with either medications or lifestyle changes. And so how do we monitor that? I think two ways. Big picture that we look at things is imaging. So how can we take pictures of the heart to see how functionally well it's performing? One, I'm sure a lot of you have seen in clinic, is an echocardiogram. So that's utilizing ultrasound waves to look at the heart. And a newer technology in the last 15 to 20 years that has been very helpful in patients with heart disease, specifically those with muscular dystrophy, is MRI. And I'll talk to you why that has some added benefit in these patients. And another way that we monitor is for rhythm disturbances. And I'll talk about all the different tools we have as cardiologists to monitor and treat rhythm disturbances. So first, let's look from a functional standpoint. So again, when we're looking by echo, we can see the structure of the heart. And usually the structure of the heart is normal in patients with muscular dystrophy. Certainly we could find mild abnormalities and we would talk to you about that. But for most patients, we're talking about monitoring the squeeze and the relaxation of the heart. And so the picture on the left here is the left ventricle. So if you see, this is the left ventricle here. The mitral valve, where the red arrow is the valve that lets the blood from the lungs into the heart. And the aortic valve up here is the valve that lets blood out of the heart. And so when the heart is relaxing, we like to see blood fill this heart with all this heart muscle relaxing nice and healthy. And remember, this heart muscle here is the muscle that's made up of those billions and billions of heart muscle cells that, if they have a protein abnormality like a dystrophin abnormality, can become dysfunctional. And so when we see a nice healthy heart, we like to see it relax fully. And then the picture on the right shows the heart squeezing down. And as you can see, the blue arrow represents how well the heart squeezed down. And that blue arrow is much smaller than the blue arrow on the left, because this heart is squeezing completely normally and pushing the blood out the aorta through the red arrow. And so we can use various types of modalities, ultrasound waves, and techniques to sort of determine the health of the heart during an echocardiogram, which can happen in the office. And as you probably know, takes anywhere from 10 to 30 minutes to perform, and gives us really good information that we can see essentially in real time, and then talk to you in the clinic about what we see immediately afterwards. And so that's why echo is a really nice tool. Over the last 15 to 20 years, though, we've done more and more research about cardiac MRI. Now, cardiac MRI is also a very good tool. It takes a little longer, and most patients need IV to be placed during the procedure to inject contrast into their veins so we can sort of light up the heart muscle cells to evaluate them better. And so the MRI is a very good tool, but does come with some downsides in the fact that it takes longer, requires an IV, and some patients can't lay comfortably for the time period it takes to perform the MRI, or can become very claustrophobic. And so we utilize this when we can, which most patients can tolerate it, but we certainly don't want to force anybody to do an MRI if they're not capable of doing so. Again, MRI, just like echo, can show us information such as the squeeze and relaxation of the heart. But one added benefit, why it really benefits our patients with neuromuscular disease, is it can tell us scar tissue. And as you can imagine, with patients with muscular dystrophy like Duchenne, their skeletal muscle becomes scarred over time, and that's what makes it become more dysfunctional, as those skeletal muscles start to deteriorate and scar down. Well, that same process can happen in the heart and cause problems. And so to highlight that, this first picture on the left is actually a cardiac MRI, looking at the heart as if it was sort of sliced through like a loaf of bread. And so this would be the left ventricle, the right ventricle, and the wall that divides them. And the simple way to look at this is the healthy heart muscle would be all of this black here. And so you can see all of this is healthy heart muscle. All of this in the right ventricle is healthy heart muscle. But as we look sort of in this area, we see a lot more white, and that arrow's pointing to that. And that is heart muscle that's been replaced by scar tissue. And if we looked at that underneath a microscope, what that would look like is healthy heart muscle cells would be your dark pink cells with the nucleus, which is sort of a purple blue. And then scar tissue is this light pink stuff that's sort of in between those heart muscle cells. And this would be sort of early to middle disease. And then as you go farther to the right, you can see a lot more scar has sort of replaced a lot of those healthy heart muscle tissues. And if you sort of think of it, this heart muscle now has made up of a lot of this scar, and that scar can prevent these heart muscles from relaxing fully or squeezing fully, or they can be areas where heart rhythms can develop sort of out of the blue. And so I think this is an important concept to know, is this is why the heart gets affected in patients with muscular dystrophy and what we can look for. And so ultimately, turning our attention to electrical, we're also looking for similar abnormalities that are caused by the same process, just manifesting in a different way. And so what we're monitoring for are fast heart rhythms, slow heart rhythms, are rhythms that can make our heart function become impaired because it's impairing the coordination of how well that heart muscle squeezes. And ultimately, why does this matter? Well, first, it matters because it can cause symptoms for the patient. So if you go into a fast or slow heart rhythm, that's too fast or too slow for the activities you want to do, you can become fatigued, you could pass out suddenly, or you can simply feel palpitation or a discomfort of your heart racing or beating slowly. That can be very discomforting. Secondly, it can start to affect how well our heart is squeezing. Thirdly, areas of the heart where the heart function is not well and the heart is beating very fast or inefficiently, clots can develop in them. And if clots develop in the heart, it could squeeze those clots out and could go to various parts of the body and cause strokes. And then finally, the biggest thing we worry about is heart rhythm issues that come on suddenly that can cause a patient to die suddenly because they're not getting enough blood out to their body that causes them to suddenly faint and to not come back. And so that's why the rhythm portion of muscular dystrophy is equally as important as the functional portion of the heart. And so how do we monitor that? I think a lot of you are familiar with the EKG or ECG that we do in clinic, which is a great tool. And if you look down here, this is sort of a normal EKG in a person where each one of these sort of cycles is a heartbeat. And if we break down each one of those heartbeats, we can see this first bump here is the upper chambers firing normally, then communicating with the lower chambers, which is the big blip here. So as you can imagine, the ventricles are the most massive part of the heart, and so they put off the biggest electrical signal. And so the upper chambers fire, the lower chambers fire, and then everything resets itself, and then it gets ready for the next heart cycle or the next heartbeat. So the EKG is a very good tool to look for baseline abnormalities to let us know if there's any changes in a patient over time. However, it's only about 12 seconds of a patient's life. And so it doesn't tell us necessarily what the patient's doing at home on a day-to-day basis when they're sleeping, when they're being more active, when they're excited playing video games, or when they're calm watching a movie. And all of that is very important to know for the electrical health of the heart. And so what you might see is we might periodically do what are called Holter monitors, which is like a take-home EKG that you wear for anywhere from 24 to 48 hours or sometimes longer, where we can look at the heart rhythm throughout a day or two of a patient and make sure that we're not seeing any abnormalities in this process over a longer period of time. Another sort of version of this is called an event monitor, and that's a monitor a patient can take home and wear for 30 days, or really as long as you allow them and the insurance company allows them, but typically 30 days is the most common time frame we'll give for a patient. This is very good for a patient who is having symptoms of racing heartbeats, but we haven't been able to capture them. And the reason it's helpful is because they can wear the EKG and it doesn't necessarily monitor them 24/7, but if they feel a symptom coming on, they can hit a button on it and it will record an EKG for them and transmit that to us as the physician so we can look at it and say, okay, you're feeling this palpitation or you're feeling this abnormality in your chest, but we have an EKG to show that your EKG is normal, so we can provide them reassurance. Or alternatively, we can say, you're feeling this abnormality and we're actually seeing a fast or slow heart rhythm that requires treatment, and we're very glad that we caught this on the monitor. And probably the last one to monitor things that is even more long-term is what's called an implantable loop recorder. And that's sort of pictured over here to the right. And as you can see, it's being held in the palm of this person's hand. It's about the size of a paperclip these days. And it would be implanted usually in the office or in the cath lab setting, and it would go just underneath the skin through a small incision and sit underneath the skin and would actually monitor your heart rhythm 24/7 and send in to us when it finds abnormalities. And it's called a loop recorder because it will record for a period of time. And if we don't get any useful data off of it, it will sort of erase itself and then start the process over. And this loop recorder can be in patients for several years, even up to 5 years or longer if the battery life allows. It can be very good for a patient where we still have a high suspicion something abnormal is going on, but we haven't been able to capture it on an EKG, a Holter, or an event monitor. And we want more time and more data to sort of determine whether or not an abnormality is present. And so that's the two ways we focus on monitoring the patient. Now I'm going to turn to treatment. And so I want to break this down into 3 categories for treatment. One is prevention, which there actually are some strategies to help prevent heart disease in patients with muscular dystrophy. Another category I think of is active treatment. So once we find disease, what can we do to treat it to help either mitigate or slow its process over time so that the patient can live a better quality of life and hopefully a longer life? And then finally, advanced therapies is a category I think of is when all of our other treatments have failed, is there anything else that we can do for the patient that might be more invasive or more involved that could help them survive longer or feel better? And so first of that category is prevention. And so just like any patient that goes to a primary care doctor or to a group of doctors, including those with heart disease, we worry about a handful of categories. Number one is certainly blood pressure. Blood pressure has been shown time and time again over decades to cause increased strain to the heart. And if you have a predisposition for your heart to become weak or develop arrhythmias, blood pressure can push that over the limits. And so we always want to make sure our patients with muscular dystrophy have normal blood pressures for their age. And so that's something we check regularly in the clinic. Also not mentioned here is as patients with neuromuscular disorders are living longer and longer into their 20s, 30s, 40s, and 50s, cholesterol, high lipids, all of those can actually become a problem later on too. And we really want to watch for those as a risk factor for developing or exacerbating heart disease down the road. A second category, and I know we have a talk about this later, which I think is a huge piece to the heart, is optimizing nutrition. And this really goes both ends of the spectrum. We have patients with neuromuscular disorders who become less and less active because they become less and less mobile, and obesity can become a huge problem. Couple that with taking medicines that make people more prone to obesity, and then things start to become this vicious cycle, and all of that can become more pressure and more strain on the heart. And so really watching our overall eating health and our overall nutrition from that perspective can really reduce the strain on the heart, and that really adds up over the years and decades as patients are living longer. Next is malnourishment. So equally, we occasionally find patients with neuromuscular disorders who are in what we call a catabolic state, where their body's actually malnourished to the point they're breaking down crucial fats and proteins. And as you've seen earlier, the heart is made up of proteins, and we do not want it to be negatively affected or malnourished. And so having a healthy diet that's well balanced actually can help your heart health as well. And a big piece of why we do a lot of these multidisciplinary clinics is not only talking to the neurologists, but us being able to work hand in hand with the lung doctors, because respiratory health is very key to heart health long-term. As we say, they live in the same neighborhood. The hearts and the lungs are both in the chest, and they really work hand in hand to move blood, oxygen, and nutrients throughout the body. And so if your respiratory system is unhealthy because you have poor ventilation, meaning you're not getting oxygen in or you're not removing carbon dioxide out, that can start to cause strain on the heart. And a more advanced portion of that could be sleep apnea, where you periodically don't breathe deeply enough or forget to breathe while you're asleep. That can build up over time and cause strain on the heart. And ultimately, what we worry about is an entity called pulmonary hypertension, or high blood pressure in the lung arteries, that can start to cause end-stage problems for both the lungs and the heart. And this is what we're trying to prevent, both with our lung and our heart doctors working hand in hand. So prevention is actually very important in these patients. Another medicine I sort of think of as a preventative from a heart perspective is steroids. Obviously, we use these widely in patients with Duchenne muscular dystrophy, prednisone and deflazacort being the names you're probably most familiar with. And a lot of people ask, well, we do this to preserve their skeletal muscle and their breathing muscle health over time. And there's good data to show that these medicines do that. But there's actually as good data to show that they can actually reduce or delay the onset of scar burden in the heart, preserve heart function, and reduce the mortality of these patients with muscular dystrophy. And these are just a couple of probably 24 landmark studies describing how steroids have actually benefited the heart in patients with muscular dystrophy. The first one came out in 2013 when I was a fellow, and I just remember what sort of a landmark study this was and how cool it was to see, hey, we're finally doing some good things for the hearts in this patients and helping them live longer, which is a great thing. Other medicines you might see us utilize in clinic are ACE inhibitors or ARBs. Names you might know for ACE inhibitors are enalapril, lisinopril, captopril. A cousin medicine to this are angiotensin receptor blockers, or ARBs for short. Those medicines would be valsartan and losartan, typically reserved for patients who can't tolerate the first class of medicine because they develop a cough or other side effects. Both are equally good and equally effective from a heart perspective, in my opinion, and from research data that's out there. And so I don't want you to remember this whole slide because it can be pretty complex, but I think this slide really helps highlight how these medicines work. And so when we start to develop heart failure because our heart is not functioning well, what happens is our body starts to produce hormones to sort of counter that and try to benefit, but it actually causes more damage to the heart. And so this is the list of all the damage when we go into heart failure that can happen in our body as a result of it. And so what happens is your blood vessels start to constrict and start to get thickened. Your kidneys hold on to sodium. Your heart muscles start to get thickened and die. Your brain starts to release more adrenaline that can cause your heart to race and other things. And so how these medicines work is the main process that happens is renin is the hormone that's upregulated or increased when you go into heart failure. And it causes this enzyme to go to this enzyme, which causes all these problems I just talked about. Well, these medicines, ACE inhibitors, block the process of this becoming the end product of bad called angiotensin II. And so these medicines help prevent all this downstream damage. Similarly, ARBs do the same thing. They just block one step downstream, again, with the goal to prevent all of this badness. And so these medicines are very helpful in heart failure. Entresto, which is a newer heart failure medication, was FDA approved in adults in 2015 and in pediatrics over 1 year of age in 2019, is actually an ARB coupled with another new medicine called sacubitril. So it's a combination medicine. Although we think this is a great medicine, there is some limited data in muscular dystrophy, so it hasn't been well studied in that population, but it has been studied a little bit, and we think it's reasonable to use. It may eventually replace ACEs and ARBs in patients with muscular dystrophy altogether, but we don't know that yet. And so right now, I think all of these medicines are equally good. ACEs, ARBs, are Entresto. All of these medicines are good, and most patients are typically just on one of these medications, not 2 or 3 of them, as sort of coupling these together can be dangerous. The next category of medications you might see a patient or your child on is beta blockers. Typical names are metoprolol, carvedilol, atenolol is another one I don't have listed here. And again, going back to our diagram, is how do beta blockers work? Well, they block one of the processes where adrenaline can sort of be shot up in patients who go into heart failure, and they try to quiet that process down by blocking that procedure. And just a more advanced slide of that, if you think about it, as your heart starts to get damaged, the squeeze goes down, you start to release more adrenaline, that starts to cause your heart muscle to get more damage, counterintuitively, more scar tissue, and beta blockers can sort of mitigate or reduce that process. A hot topic in patients with muscular dystrophy is our aldosterone inhibitors. Common names are aldactone or spironolactone, that's the same medicine, or eplerenone is a similar medicine, all in the same class. And how aldosterone inhibitors work is sort of block some of these processes over here. So same diagram, but blocking some of the downstream effects of this bad guy called angiotensin II. And this medicine is very helpful. I think I have it on the next slide here, is it's been shown to helpfully reduce scar burden in patients' hearts with muscular dystrophy. And so it has some added benefit to some of the other medications we talked about. Now turning the page to advanced therapy. So those are medicines, obviously, we can take once or twice a day in pill form or liquid form. Very easy to use. They do have some side effects, but most of them are tolerated, or if we develop side effects, we can do lower doses or sort of different medicines in the same class to sort of get those. But those are medicines we have patients on typically in their teenage years, and can be on those medicines for decades and decades. Well, the question comes up, well, what if these medicines start to fail? What else do we have in our cabinet of therapies to offer patients? And so here's just a list of them, and I'll talk about these each briefly, but ICDs are implanted sort of defibrillators that can shock you out of a rhythm when you go into a fast heart rhythm. Pacemakers, ablation, I'll talk about, ventricular assist devices, and heart transplant as well. And so ICD is a device that we typically put in patients who have very low ejection fractions or squeeze of their hearts, or they have a history of known fast heart rhythms that weren't controlled on medicine. So we found them on one of those monitors we put on the patient earlier. We tried medicines first, but they're still having a lot of these fast heart rhythms, and we feel like these fast heart rhythms could become even more dangerous with time. A patient might have an unexplained passing out spell that worries us that it was a rhythm thing that we did not catch. Or of course, they had a history of a sudden cardiac arrest and were resuscitated by somebody because there was an AED or CPR was performed, or they were in the hospital around medical care providers who resuscitated them. Those would be sort of patients that we would identify as possibly benefiting from an ICD. And this has actually been studied recently, just out last year, was what have we done in the past with ICDs in patients with Duchenne muscular dystrophy and severe left ventricular dysfunction. And people have utilized it successfully, but we really like to make sure we only do it in patients who would truly benefit from it and not have any harm from it. So we pick a select population. And so how it works is it's monitoring your EKG all the time because it's implanted usually under the skin and muscle in the left upper chest, but sometimes under the left arm. And there's a wire that goes into your heart that monitors your heart rhythm all the time. And so it's basically constantly looking at your EKG. And if you go into a fast heart rhythm like this, as you could imagine, this patient's heart rate on the left would be 60 beats per minute, which is healthy and good. This patient's heartbeat would be 300 times a minute, which would be fatal if they stayed in that for more than just a few minutes. And so this ICD can identify this abnormal rhythm and provide an electrical shock to the heart to reset this and get it back to this rhythm as our hope. And so as you can see, this can be a very life-saving therapy for patients. Similar along the same lines as pacemakers. Not only do we worry about fast heart rhythms, but we worry about slow heart rhythms. So if you look at the EKGs on the bottom again, a normal EKG, upper chambers communicating to bottom chambers, resetting, upper chambers, bottom chambers, reset. Compare that to the EKG on the right, upper chamber here is firing, but there's no lower chamber. The lower chamber later on does its own thing, upper chamber firing, doing its own thing. Well, there's no communication between the upper chambers and the lower chambers. And as a result of this, this patient's heart rate is much, much slower, around 30 or 40 beats per minute, which could cause us to pass out, to have very low energy, or in some patients can even cause sudden death. And so if we identify a abnormal EKG like this, we might place a pacemaker, which can actually be implanted very similarly to how the ICD is, and then can start communicating these upper and lower chambers better and prevent these problems that we're seeing. And another benefit of pacemakers, I won't go into too much detail, is when sort of the heart rhythm between the two bottom chambers is not communicating well, the heart can start to contract less and less well. And sometimes pacemakers can override that abnormality and get the heart functioning better. And so there's another indication for pacemakers in some patients. Another category is ablations. That's where a catheter-based procedure is performed, and a catheter has gone up through the groin, through a vessel in the leg, traced up to the heart, and we can identify where that potential fast heart rhythm is and apply either heat or shock to that area and prevent that area from becoming a problem in the future. Another category is ventricular assist devices. I don't want to go into too much detail here, but we have temporary and permanent ones. These are devices that can be placed for patients whose heart squeeze is so low they're not getting enough blood out to their body. These would be patients in an intensive care unit initially, and this would be a way to get more blood out to the body. And we can place temporary ones to see if they can recover on their own. One category for that would be patients with like myocarditis or inflammation of the heart that needs time to recover. And once it recovers, this device can come out. Alternatively, permanent ones can be placed for a patient for the remainder of their life or as a bridge till they get a heart transplant. And so here's just a look at a temporary one called an Impella. This is a device that would be put in through a vessel in the groin, traced up through the aorta and placed into the heart here. A motor rotates through here and pulls blood out of the left ventricle that's not pumping well and puts it into the aorta or the body artery to get the blood out to the body so that this patient has a good blood pressure and can get enough oxygen and nutrients to their organs. Other modalities are ECMO and PDMAG, CentroMag, which I don't have highlighted here. Other options are permanent ventricular assist devices. These are surgically implanted in a patient with the goal to get them home. This is the HeartMate 3, which is one of the more common ones placed these days. This would be the pump here placed in the patient's left chest with a cannula going into the heart to pull blood out of the heart and put it into the aorta, again, to bypass the failing heart pump. The only thing sort of coming out of the patient's body would be a drive line, which is about a pencil width cord that would come out of their upper abdomen, hook up to a CPU that can be connected to batteries or to a wall unit that's plugged into the wall. And again, this diagram here just highlighting the cannula that pulls the blood out of the heart and then pushes it out to the body. Some people ask on occasion about heart transplant. So when all else fails, what has been done in the past for heart transplants in patients with muscular dystrophy? If you look, there's been almost 42,000 heart transplants for cardiomyopathy over a approximately 30-year time span up to 2016. Only 81 had been done for patients with muscular dystrophy, the most common of that being Becker and a few others. And if you look, only 3 patients with Duchenne muscular dystrophy had been transplanted. And so I like to think this is an option in some patients who have end-stage heart failure with muscular dystrophy. But there is this fine sort of window when a patient is sick enough to need a heart transplant, but not so sick that they're not a candidate. And so we have to make sure the rest of their body is healthy, meaning that their lungs, their kidneys, their liver are healthy enough to accommodate a heart transplant, because the goal is to get them to live several years longer. If we do a heart transplant in somebody and they only live 3 or 6 months after heart transplant, there's a lot of things that they have to go through for recovery that 3 or 6 months is not a good enough outcome for them. We want them to live years and years. And if we don't feel like we can get that outcome for them, they might not be a good candidate for a heart transplant. But the short answer is patients with muscular dystrophy have been successfully heart transplanted. Again, it relies on careful patient selection, making sure that their skeletal muscle isn't going to have a worsening stress during transplant that could put them on a ventilator permanently. And we always have to know that there's limited donors and hearts. And so we just have to be very thoughtful of which donors that we select for which patients. And as a result of that, patients that can actually die on the heart transplant list. And that's something we deal with on a regular basis. One other topic of medicine, and I'll sort of start finishing up here, is exon skipping medications. People always wonder if this is going to benefit the heart. And the short answer is we're hopeful. We just don't know yet. And so if you've heard of exon skipping medicines, I sort of think of it in 3 categories. DNA is sort of the archive book. mRNA is more like the printing press. And then our protein is the newspaper that comes out. Well, in Duchenne, we have an abnormality in a gene that causes our mRNA to have sort of a missing piece of that. And so the printing press is printing out either the wrong newspaper or not the newspaper at all because it can't make sense of it as the end product. Well, exon skipping medicines try to eliminate that gap in the mRNA so that the patient can still make protein that can still be functional. And so you still get a newspaper. It might be missing a few sentences or a few words, but you still can get the gist of it as the end product. And so we're seeing benefits of patients' skeletal muscles on exon skipping medications if they qualify. The question is, will their hearts also benefit? And we would think, yes, it would, because the same genetic process is happening in the heart as it is the skeleton. But the main issue is making sure this medication, as it gets delivered through the IV, actually can penetrate the heart and do this process in the heart muscle. And so research is going on coming up with various cocktails of these exon skipping medications that allow it to penetrate the heart so that it can do this process and skip the exons and make protein that might be better than no protein. Just a quick slide. This is a few years old from one of my partners, Dr. Markham, just to talk about all the research going on in Duchenne's muscular dystrophy. This isn't even all of it, but I just want people to realize just how much effort is going on across the country, and certainly more needs to be done until we cure muscular dystrophy across the board. And one final plug I just want to make sure everybody's aware of is carrier females. And so patients with specifically Duchenne and Becker muscular dystrophy, mothers or females in the family can be carriers of it. So we know 70% of patients with Duchenne muscular dystrophy that they got that genetic abnormality from their mom. So one of the abnormal X chromosomes that came from their mom went to the son, or rare occasions the daughter, and they don't have enough of that dystrophin. And so of that 70% that comes from their moms, 60% of those moms can develop heart disease as well over the span of their lifetime. It tends to be much milder, tends to be a little later in life than we see in the males with Duchenne's muscular dystrophy, but it can happen. And so the short purpose of this slide is to make sure all carrier females, or those with unknown carrier status because they haven't got genetic testing, need regular cardiology surveillance. And that typically means getting at least an EKG and an echo. And if things look normal, then periodically repeating that every 3 years or so. And so making sure that you know that. And then of course, if you get screened and you have cardiomyopathy or heart muscle abnormalities, making sure that you're seeing a cardiologist who's versed in taking care of patients with that is very, very important. And so conclusions, the heart involvement is very common in all forms of muscular dystrophy. Almost all of them, with a few exceptions, we assume will have heart involvement. It's just a matter of how we do our surveillance program. It determines how often we see them and what tests we do at each year that we follow them up, or each 6-month period that we follow them up. There's good treatments that exist. They're not perfect, but they're better than they were 20 years ago and even 10 years ago. And these treatments can actually improve the quality and longevity of patients with muscular dystrophy's life from a heart standpoint. And a big topic, I think, is optimizing your overall health with nutrition, mitigating risk factors like hypertension, hypercholesterolemia, and making sure you're seeing your other specialists, because making sure those organs are healthy helps the heart out. And female carriers, as I just said, need to be followed. And so I'll end that and stop my share here and open up the floor to any questions. I see one question on there I think I can read out loud for everybody. It says, can muscular dystrophy cause heart abnormalities and dysfunction without showing fibrosis on an MRI? And the answer is yes. And alternatively, the alternative answer to that is, can you have no dysfunction and no heart rhythms and have just scar? And that can also happen. And so that's why I think a lot of centers are moving to sort of alternating echoes with MRIs on a patient once they get to an age that they can lay flat and still for it. And so most patients, that tends to be the earliest I've ever done an MRI on a patient and not require general anesthesia, which is a big piece of this. We don't want to necessarily put a 5 or 6-year-old under general anesthesia for an MRI when we know the likelihood of finding something is exceedingly low or almost zero. So we want to wait till they can lay flat, and that can be as early as 7 or 8 years of age. The average is probably around 9 or 10 years of age, and some patients, like we talked about earlier, can't ever undergo an MRI. But it's an important question, and we really want to find the earliest stage of heart disease, because we have various heart medicines we can use to start changing or slowing that process down, whether it's eplerenone or aldactone or ACE inhibitors or beta blockers. How we treat that depends on what we're finding either on the echo or the MRI. And so I think that's a really important question that you brought up. Good. Any other questions? All right, well, I want to thank everybody again for their time, and Kristen for arranging this and helping me get everything prepared for this. I appreciate it. Thank you.
Thank you so much, Dr. Parent. We really appreciate the time you took to come today, and we thank you so much for all that you do for the neuromuscular community. So thank you so much.
Thanks. Have a good day.
All right, so here's the updated agenda for the rest of the seminar today. For those of you joining the event live, please know that all phone lines have been muted. And just as a reminder, we will be having a Q&A session at the end of each presentation, so please feel free to utilize the Q&A icon to type in your questions. Feel free to use the chat feature during this seminar as well if you do have any comments, and make sure that you click on all panelists and attendees when you type in your comment. Hello and welcome back to the Pediatric Neuromuscular Care Seminar. I would now like to introduce our next speaker, Kelly Bell, who will be presenting on the importance of nutrition in children with neuromuscular disease. Kelly Bell is a clinical dietitian who joined Nemours Children's Health in 2018. She works with a neonatal and pediatric intensive care patients to provide nutritional health assessments and also serves as the neuromuscular dietitian for the Muscular Dystrophy Association Clinic at Nemours Children's. Kelly is an adjunct professor of nutrition at Valencia College. Prior to coming to Nemours, Kelly was the nutrition services manager for BI at Greyhawk, a 90-bed long-term care facility, and gained experience in pediatric nutrition through Cardon's Children's Hospital and Phoenix Children's Hospital. Kelly spent time working with malnourished children as part of her dietetic internship in Tanzania, Africa. She also served as the community relations director and exercise therapist at BackFit Health and Spine. Kelly earned her Bachelor's of Science in Kinesiology and Wellness Development at Pennsylvania State University before completing her Master's of Science in Nutrition and Dietetics at Arizona State University. Kelly is a member of the Academy of Nutrition and Dietetics as well. Thank you so much for joining us today, Kelly, and I will go ahead and pass it off to you.
Well, thank you very much. Thank you for having me today. I'm going to go ahead and share my screen with everybody. Well, thank you. Yes, my name is Kelly Bell. I'm with Nemours Children's Health System, and I am very happy and honored to be with the MDA today to talk about the importance of nutrition in children with neuromuscular diseases. So thank you all for attending, and any questions at the end are absolutely welcome. So really, when we think about nutrition, it's important for all of us. Nutrition is something that can really help keep our health going the way we want it to go. So with neuromuscular conditions in particular, this is very important, especially in our childhood years, because we want to make sure that we're growing appropriately. So nutrition is something that's going to help optimize, maximize the growth potential that we do have in our children. It also helps us to prepare and create that foundation for the adulthood years. So that's our goal. As we're parents raising our kids, we want our children to have the best that they can have so they can make it to their adulthood with having a good quality of life. And the big part of this is having a good balance in their weight. A lot of times when I'm meeting my families for the first time, I'm explaining my role with our whole care team. And really it's about making sure that we're reaching those growth potentials. We're not gaining weight faster than we are growing long-wise. We're not carrying too much weight, but on the other end, we don't want to be too underweight either. So we really want to get that balance going on. And of course, we want to optimize every physiological function. So nutrition is going to help give us that backing and strength for treatment plans that we're on. There's a lot of new treatment options out there for many of our different neuromuscular conditions. So we want to make sure that nutrition is helping to support that, not hinder that. We also want to make sure that we have the right nutrition if and when our child gets ill. We don't want that to happen. You know, especially in today's world, we are really taking a lot of precautions. But if some sort of illness does strike, we want to make sure that we have the right nutrition so we can recover from that and get back to a better place with that. So how do we think about doing that? If we're thinking about nutrition, it really starts from the ground up. In our infancy, at this point in time, your child may or may not have been diagnosed with the neuromuscular condition. So it just depends on which type it is, what kind is out there. We now have some newborn screening that is showing us that our child is carrying or has the potential of having some sort of neuromuscular condition. So in the infancy years, we want to make sure that we are achieving our growth goals. And this is a time in our life when there's rapid growth. So we want to make sure that we're getting that nutrition into the body and achieving and meeting those growth goals. We're also developing our feeding skills, and this travels into those toddler years too. We don't think about it very much when we are eating, but it's actually a muscle activity. So certain neuromuscular conditions might have some difficulties with achieving those feeding skills and learning those feeding skills. So we want to make sure that we're getting our nutrition into our body again, especially if there's anything that might be impeding on those feeding skills. And of course, in our toddler years and our childhood years, there's a little bit of a fear factor with food. And it's not the worst thing ever that kids are like this. They're not going in the backyard and eating something that they shouldn't eat. But we also want to make sure that we're encouraging them to try new foods. And that could be, not could be. It almost always is a very frustrating experience and journey in trying to get kids to try some of these new foods. So we want to make sure that we're okay with that. And we could have some tolerance issues to some of our foods. Again, it depends on the neuromuscular condition and how we're getting nutrition into our body. But there might be some things in our digestive system that just aren't letting the food get into the body, or it's not going through very easily. So if we have some hangups there, then we have to start addressing that and figuring out what to do with it. And of course, as we get older into that adolescence time period in our life, we're still growing. So even though growth has slowed down, we still want to make sure that we're getting that balance of body weight in there and making sure we're meeting all of our nutrition needs. And then of course, we're really watching bone health. This is something that oftentimes my parents are surprised that the dietitian is focusing on. But really our muscles, every muscle in our body attaches into our bones. And so muscles really do two things. It's contracting, tightening up, and relaxing. Those are the two actions that our muscles do. And when they tighten up, they pull at the bone that they're inserted into. And that kind of stimulates that bone to start growing. So if we have a neuromuscular condition, our child with that neuromuscular condition not going to have that same stimulus on the bone. And we want to make sure that we're getting those bones nice and strong. We don't want to have weaker bones and then risk of fracture. So first and foremost, your dietitian is going to make sure we're getting those bone building nutrients into our body. And then we start to monitor to make sure those nutrients are going into the bone appropriately so. And we might have to get some other members of our care team involved to help get that bone health going where we want it to go. So as we're watching this through the lifespan, we're going to be looking at these growth charts. And the growth chart, I'm going to pretend that no one has ever explained it to you. So with this is an example of a growth chart here from 2 years to 20 years of age. And our goal is that you fit somewhere on the lines here. Now for many of our neuromuscular conditions, they're rare enough that there isn't a specific growth chart lined up for that neuromuscular condition. So we still compare it to our CDC, Centers for Disease Control growth chart. And the goal is still to make sure we're somewhere on the lines. That's based on the genes that we're given, and nutrition impacts that as well. And we want to see that we pick one of the lines or in between the lines, and we kind of follow through the wave here. Now, again, it depends on the treatment plan. It depends on the neuromuscular condition where we may or may not follow along that line. For example, in some of our neuromuscular conditions like Duchenne, where we may have some steroid treatment, our linear growth, us growing longwise, gets compromised, and so we might start to see that kind of slow down a bit. But that's one of the things your dietitian will be monitoring to make sure we're still meeting growth goals, and if we're not, we may again have to get some other health team members involved to help promote the best balance that we can get. So some of the goals that we're looking for all of us, we all have to eat, is to make sure that we're getting the right balance of nutrition. Even if it's a good nutrient, there is still a such thing as having too much. Nutrition is really all about balance, not having too little, not having too much. The number one question I get when I meet my families is, what kind of supplement can I take? Is there something out there that I can do in addition to food to really maximize the quality of life and the chances for my child? The reality is there's not strong evidence for any of the neuromuscular conditions that I've come across where there's any particular types of supplements. We'll continue talking about some nutrients that we really focus on where there might be some individualized cases where supplementation is appropriate, but nothing off the bat where we say, oh, you got diagnosed with this name of a condition, here's what you have to take. Really, we want to make sure you're getting enough nutrition and that balance is in there to promote meeting those growth goals and getting enough calories, not too many where we're gaining weight too quickly, not too little where we're struggling to gain weight. There can be some implications and some problems if we're over or underweight, so we still want to get that balance in there. And this is very individualized. Certain conditions, we might have some patterns and some knowledge that we're looking for, but really every person is going to have a slightly different nutrition plan that goes along with it. And we want to think about what happens when we get sick. Now, we're taking great precaution, and I love that. We want to keep doing that, but really kids tend to get sick. And when we don't feel well, we don't eat well. So we always want to make sure that we have some sort of plan in place to get at least a little bit of nutrition to bridge this gap while our body is fighting off whatever pathogen we have. We also want to try to prevent long-term sicknesses, especially for those kids who might have cardiovascular risks. We want to make sure we're getting the right nutrition into our body so that we can promote a good quality of life and keep those organs nice and healthy as long as they can be. And again, that's something we all benefit from when we make good, healthy nutrition choices. And of course, bone health, we're watching to make sure our bones are staying nice and strong throughout the lifetime. And bones are really building during our childhood years. It's much more difficult in the adult years to really get those bones nice and strong. So we really want to try and optimize that during those pediatric years. So some of the things we're going to focus on when we're having our clinic visits is checking our nutrition. First and foremost, we're checking how you're growing. So anthropometrics is just a fancy word for measurements. We're going to check your weight. We're going to check your height. In our clinics, we do this diligently. If it's been a minute since your wheelchair has been checked and weighed, we're going to take you out of that wheelchair. We're going to weigh you. We want to try, if you're a younger child, we want to make sure that we have any kind of clothing that could be weighing you down, diapers that could be weighing you down. We want to make sure those things aren't going to be part of that weight. We really want to know from visit to visit, how well are we growing? Are we gaining weight too fast, too slow? What is happening with our growth? Same thing with linear growth. Are we getting taller appropriately based upon our age and based upon our condition as well? So are we meeting those growth markers and goals? Really watching that and checking to see what's going on, especially if we're starting new treatment plans. Some of our treatment plans might increase our appetite. Sometimes they can impact how we're taking our nutrition, how we're utilizing our nutrition as well. So we want to focus on those things. There's something that we do with our physical exams. We're checking to see, do we look well nourished? A lot of times I'm with my families, the children are playing. They don't necessarily know that I'm looking at their nails, their eyes, their mouth, their gums, their teeth, their tongue, to see, does everything look like it's intact, or do we see any physical signs of nutrition deficiencies that we might have to address and check through different things there. Of course, we want that balance. Too much or too little of nutrition can be a bad thing. So we want that balance. We're going to focus on checking labs. It might be certain labs that we want to check, or maybe I took a look at the physical body and something looked off, and now it's time to check a lab and see what's going on the inside. We'll talk about what we're eating so that we can check and see, is there anything else that we have to look further into? And again, that bone health, a lot of our conditions, especially if we're not able to walk and bear weight, we're going to be checking to see how your bones look. So ways of doing that is at least annually checking for a vitamin D lab to see what our vitamin D levels look like. We might have to supplement with vitamin D. First and foremost, we want to check the labs and see what kind of levels our body is already storing at that moment. So that's going to help us to see, do we have the right nutrition in place to keep those bones nice and strong? We also do some DEXA scans. These are ways of actually checking to see how strong your bones look. And if they're going to be on the weaker side, do we want to get some other levels of care involved, like an endocrinologist, to be able to help keep those bones strong? Benefit with the DEXA scan as well, it can give us a body composition. It's limited if your child has any kind of spinal rods, any metal like that. Sometimes we can't pick up some of the information, but in many cases, we can get the body composition. We can see how much percent the body is of fat tissue versus lean tissue. And we can watch that over time. If we do this once a year and we're checking, we can watch and see how that's changing over time as well to get a full picture of what's going on with the nutrition in our body and how we're storing it, how we're growing with it, and what do we have to do to keep moving forward. So some of the things that we really focus on is trying to be proactive and preventative with some of the things that can be precautions we have to watch out for. And first and foremost, weight maintenance is a big one. Making sure that we're not going into the overweight zones and making sure that we're not underweight either. Both can have some negative effects to it. So we want to keep us in that balance. So for your younger children, soon as we find out there's a neuromuscular condition going on, and if we're still able to eat by mouth, we want to get some consistency going on. This actually benefits everyone in the house. We can get some sort of pattern. If we are making sure that we're eating something, our growing bodies are eating something every 2 to 4 hours, meaning we're having 3 meals a day, 1 snack in between there, depending on the schedule and our nutrition needs. We can have somewhere between 1 to 3 small snacks in there. We want to try and keep at least 2 hours off of eating, and we want to make sure we're not going more than 4 hours apart from eating so that we can keep giving that opportunity for fueling the body and giving our growing children some nutrition. Now, as we get older, we might not have as much activity ability, and that means our nutrition needs are going to go down, especially our caloric intake. So we don't want to take in more calories than we have the ability to burn through different means of exercise and movement. So that might start to turn into having 3 to 5 small meals, not large plates of food, but just a small meal throughout the day to, again, keep fueling our body, but not overdoing it, finding that appropriate balance. We certainly want to avoid grazing. And this is something that benefits every child. Again, we want to try to make sure that we're having that one small snack, tides us over, curbs our hunger until that next meal, but we're not grazing. We're grazing if we're just kind of eating food throughout the day whenever we feel like it. It doesn't allow us to really truly feel when we're hungry, and we sometimes lose that focus on our food, so we miss the point when we feel satisfied and full. And any child that's on any treatment options that are increasing their appetite, especially those that take steroid medications, appetite can go up where it's difficult to feel that sensation of I'm full, I'm no longer hungry. We would have some very big challenges if we're grazing throughout the day. So keeping that schedule is very important, particularly for our Duchenne population. If we know they're about to go on a steroid, even if they have not done so yet, I'm counseling the parents and working with our children so that we create this schedule first and foremost to make that expectation known so that if they feel that side effect of increased hunger in starting that steroid therapy, we already have that pattern, that expectation's already there. So we already know this is our schedule. If I feel hungry between that, we're gonna wait until it's time to eat. And of course, we want to make sure in that schedule, we're keeping our bedtime routine consistent as well. Sleep is incredibly important for that quality of health. And if we're noticing we're having trouble with sleeping, that's the time to work with the pulmonology team to make sure that we don't need other breathing support at night. We want to make sure we're getting good quality of sleep. That's the time that our body's using our nutrition to keep us healthy and growing well. So if we're thinking about our neuromuscular kiddos who are eating by mouth, we want to set the stage for a good, healthy plate. And again, this is something that can benefit all of us. So we want to have that good, healthy plate. And you notice on this plate, it's not too big, not too small. Half of our plate is going to have fruits and vegetables. Depending on the meal, it might be all of our non-starchy vegetables on half of that plate. We want to make sure that we're making room for some of these low-calorie foods. They're also very high in fiber and full of nutrition. A lot of vitamins and minerals can be found in these foods. Now, if you have some of the younger kids who are in that fear factor stage, it might not be their favorite food. But again, we want to make sure that it's on their plate. They have the opportunity to taste it and try it. We can't force them to eat it. All we can do is encourage them. Encourage, so that they can have the opportunity to taste it and try it. Of course, we want to include a little protein with that meal and a little bit of our carbohydrate foods or starchy foods. This could also be some starchy vegetables in there too, where we're giving just a little bit, but not going overboard where we're filling it up with the whole plate. Of course, a good low-calorie plain dairy is great calcium-rich food sources. You can also do fortified non-dairy. That's okay too. That's going to be fortified with calcium, and it's a great opportunity to get those bone-building nutrients in there. Now, if we have an underweight kiddo, we can do some of the higher whole milk products, but if we're noticing we're having trouble and we're gaining too much weight too quickly, that's when we want to do the reduced calorie. A little bit of heart-healthy fat is going to also be beneficial. This actually helps us to feel full just a little bit longer. For our kids who need some weight gain help, heart-healthy fats layered onto the food is a great way to calorie boost their food. If they need a little extra nutrition to gain weight, something like an avocado oil, grapeseed canola oil, they have no flavor to it. You can just sprinkle that on the food and give a little extra calories. If we are having trouble in gaining too much weight, we do want to watch how much we're using of these heart-healthy fats. Just a little bit goes a long way. A teaspoon is about 40 extra calories. But the nice thing is it can help you to feel full a little bit longer. And what it's also doing is these heart-healthy fats, we call them unsaturated fats, it can help your cholesterol levels go in the right direction so that you're going to have a better heart health in the long run. Now, for our younger kids especially, or any kid where we're having portion control challenges, we can use our hands as a good measuring tool way of doing this. So everyone's hand size is different, and as our hand grows, our portion gets to grow with it. But we can use some of these tips here to help portion out some of our foods on that healthy plate. As we're getting older and we might have lower calorie needs where we don't want to gain too much weight, we talked about having those 3 to 5 small meals. You can even cut this in half and just do smaller portions of that food to get a good taste for everything in there too. Now, of course, we might have that challenge of feeling hungry, so healthy snacks in between are very important, especially if we're going more than 4 hours apart of eating. We want to make sure that we're getting a good healthy snack in there. It's nothing too big. It's a great idea to do a fruit or a vegetable and pair it up with a small portion of protein. And that protein doesn't have to be a lot. It's just enough to give you a little bit of something in your body, and it actually helps you feeling full a little bit longer too. Now our kids, they love to have different things like chips and the Takis are big and popular right now. We do want to try to limit that. Always look at the food label, take a look at how many calories are offered, and offer a pre-portioned amount. Some of those foods, again, if we're eating by mouth, we can do once in a while. We don't want to restrict them completely, but we want to do more healthy options more often so that we have all this good nutrition in our growing bodies. So you can see some of these smaller protein portion sizes. These are about 7 to 8 grams of protein that get paired up with a fruit or a vegetable. So it stays a low-calorie snack. And again, if our kiddos need a little extra, we can throw in some extra calories in there too to give something else with it. But this gives it something so that we're fueling our body throughout the day. And here's some other examples for you too, of just a small snack idea. For those kiddos with the increased hunger, this can help curb their hunger. And that little bit of protein really helps to curb the hunger a lot. We also want to make sure we're drinking enough. We'll talk about that in a moment. But sometimes when we're underhydrated and we're not drinking enough, we don't always feel thirsty with that. Sometimes we feel hungry. So we want to make sure we're encouraging water intake as well. Now, if we're not getting enough nutrition, we could have the opposite problem. And here's the real big risk with not having enough nutrition. When we are going a long period of time without eating or fasting, our body starts to pull on our own stores for nutrition. And if we're fasting long enough, our body's going to start to break down muscle. Now, if we have a child with neuromuscular condition, we're not going to be able to rebuild that muscle very easily. So here's where a sick plan is very beneficial. Coming up with some sort of plan to give some sort of nutrition so that we have a little bit of something in there to help minimize any muscle breakdown from when we're not getting enough to eat. So this is something that we want to definitely make sure we are being proactive about discussing in your care plan visits so that we can figure out what do we do when our child doesn't feel well and can't eat very well. We also might have different means of eating because there could be a lot of gastrointestinal complications with our neuromuscular conditions. So some of these things create that barrier to taking nutrition in. A lot of times, because again, we don't think about it, we have all these muscles around our mouth, our face. Swallowing and chewing can be a challenge. This might start early on if we have some other of our neuromuscular conditions where we don't have that good feeding skill ability. It could happen later if muscles start to not work quite as well, and our child is starting to struggle with some of our swallowing and chewing abilities. Getting swallow studies the moment that we feel we're not quite eating very well is a very good idea. If we're not swallowing properly, it can go down the wrong way and get into the lungs, and then we have that higher risk of upper respiratory issues. So we don't want to have that. We want to make sure that we are getting that nutrition and it's going into the body. Otherwise, we can't use it if it's not actually going into the GI system the right way. A lot of our children with neuromuscular conditions, the muscles around that torso area not developing in a way that we can create enough space. And so now our stomach, if it gets too full, it competes for space with the lungs. We start to have some breathing issues, or we might have some challenges having that food in the stomach just empty out at a good pace. And so with that, we might start to have some intolerance with the food that we're eating. This can happen if we are doing our tube feedings or enteral feeds, or if we're eating by mouth, where it's just not leaving the stomach fast enough. So now it's going to start to come back up, or it's going to just stay there and compete with the lungs where we're having some breathing trouble. So we want to try to talk about these barriers early on as well, come up with those plans of if this happens, then what do we do? And of course, as our food is moving down our GI tract, what goes in is going to have to come out. So your dietitian on your care team is going to talk to you about bowel movements and how we are stooling and pooping. Every child is going to look surprised about this. We don't always like to talk about it, but this is a great conversation to have at home every day. We want to make sure our food is flowing through. So we want to make sure that we are having a bowel movement every day. Every other day might be the case, especially if we have lower calorie needs, but it's very common to see constipation issues with our neuromuscular conditions. We actually have muscles that are surrounding our intestinal wall, and they do a process called peristalsis. It's a muscular activity. Now, those muscles might be on the weaker side, but the muscles in our core torso area also stimulate those muscles. So if we are not able to move around very well, we might not have that same stimulus. So that's going to make it harder for the non-digested food to move through our bowels and have that bowel movement. So sometimes when we have these complications, we have to create some alternative ways of getting nutrition. The most important part is that we have the nutrition go into our GI tract and into our bodies. So when we have some of these barriers, we have to think about what can we do to try and compensate for it. This might be the time that we have to do some supplementing. We might have to take a multivitamin or specific nutrients based upon our needs. We might have to do some modifications to our food to safely swallow it so that it's easier to chew. We might also have to do some things where we are having some liquid nutrition. It might be easier to drink the food than it is to chew and eat it. Maybe a combination of all of those things. When we have lost that ability to chew and swallow, but the rest of our GI tract is still working, then we can do what's called enteral feeds. It's just a big fancy word for saying we're still using our intestinal system here. So we can do some short-term things where we do a nasogastric tube. It's just a rubber tube. We can actually still eat by mouth in some cases with this, but maybe we can't eat enough. Maybe we don't have enough muscular strength to eat all the calories that we need. This little tube can go down into the stomach or maybe even past the stomach into the intestinal wall and deliver some liquid nutrition to help us meet the rest of our needs, to continue giving us the nutrition that we need. If we know that we're going to need this long term, we might have to get a gastrostomy tube, G-tube for short. And this is something where we have our stomach right here in the middle. Instead of having that tube taped onto our face and having to worry about swallowing with it, we now know we're going to be using this long term. So we create a little pathway right through that skin there into the stomach so that we can deliver the liquid nutrition right through there. Now, parents, this is often a scary thought, and this could be all different types of ages as to when we're doing a G-tube if we need it. I've had many younger kids where they just couldn't get those feeding skills developed quickly enough, so we needed nutrition. We did a G-tube for several years, and then at some point we were able to not have to use it anymore. I've had children where as we got older, muscles just got a little weaker and we had to get that G-tube, and that helped us to get the nutrition in that we needed. Now, I will tell you, all of my parents and children who ended up getting it, they said, yes, I was more nervous about it, but after the fact, I'm glad I have it. This is especially helpful for a sick plan when we're not feeling well enough to eat, or if we can't take in that nutrition, we have that means of being able to get nutrition in there. And we have a good sick plan in place where we can give some enteral liquid nutrition as a backup plan. So there's alternative measures that we can do to help providing the nutrition. Bottom line, what we don't want is to miss those opportunities of receiving the nutrition that we need, especially with our children growing. They could miss that growing opportunity if they don't have the nutrition entering into their body. Now, again, if we're eating by mouth or enterally, we will make sure that we're having those bowel movements. So we want to look to make sure that we're pooping every day or every other day if we're not getting a lot to eat. This is a conversation that we definitely want to have with our children. It's funny to talk about for many of us, but it's also very important. Our bowel movements will tell us how our nutrition is being absorbed. So we want to take a look and talk about it. We want to try to have between type 3 or 4. It might be something where we see something pasty. It might be a little more formed. We certainly don't want to be straining and struggling with it. And we want to make sure that we have enough hydration and fiber to create that stool. A lot of our stool is going to be the fiber in our foods, our fruits, our vegetables, whole grains, legumes, beans. These are foods that have that fibrous component that our body doesn't have the means to break down. So it helps to create the bulk in our stool, and it also helps to just run through our body and keep us healthy. It helps to keep our cholesterol levels where it should be. So a lot of beneficial things happen when we have that fiber. The fiber stimulates some of that peristalsis muscle activity in the intestinal area there. Water, though, is going to be very important with our fiber. If we have tons of fiber and not enough water, it's going to plug us up even more. So we want to make sure fiber and water work hand in hand. We're drinking enough to keep our stool nice and soft so it can flow through. It's not uncommon if your child has a neuromuscular condition that you need to also use some sort of laxative or bowel care regimen. And these are safe to use every day. So this is something you can talk with to your care team if we're having struggles with bowel movements and we've really optimized our nutrition opportunities. We can do some bowel care regimen and set up some sort of system to help get that bowel movement going. You might still have a child that's still eating by mouth and struggling with some of these high fiber foods where they don't want to eat it. There are fiber supplements out there too that we can use as an option to help keep that bulk in there and keep those bowel movements going. Now, our fluid needs are going to be very different for everybody. It's very individualized. It can be based on age, body weight, especially for our growing kids and our younger pediatric kids. We might have higher increased needs depending on the condition. For some of our kids with neuromuscular issues, they might not have the strength to get rid of some of the secretions that they have. We might have extra secretions, and oftentimes that means we have extra fluid needs as well. So these things are not uncommon where we have to make sure we're getting enough fluid in our system so that we have that right balance. And of course, we don't want too much because that could strain the heart. So we want to find the balance. Again, with nutrition, everything is about not having too much, not having too little. So we want to find that good balance in there. Some of the options for our fluids, yes, water is the best option. So we want to try to limit sugary beverages. Even if your child needs to eat a little more, those sugary beverages can actually stifle the appetite. So we want to limit that as much as we can. We can flavor our water as much as we want. It's a-okay. And there's a lot of sparkling, bubbly waters out there that you can flavor. So it can give a better feel for it if we're still eating by mouth. If we're doing our enteral nutrition, if we have a G tube or we have an NG tube, this is a great opportunity to stay hydrated. I have many children that they've been able to eat by mouth, but drinking is just a challenge to get that nutrition in there. So we can give some water boluses to make sure they're getting enough fluids that way. And of course, our calcium fortified beverages are a fluid option as well. So this counts towards the fluid that we're taking in. And last but not least is our bone health. This is a big focus when we are making sure that our neuromuscular kids are staying well nourished and healthy. So the bone building minerals and nutrients that we're looking for, there are many of them. We are paying attention to magnesium, vitamin K, phosphorus. We want to know that we are getting everything that we need. Now, calcium and vitamin D are big tickets right there. We are going to check and do at least annually a DEXA scan. If your child is non-ambulatory, we want to make sure that our bones aren't too weak where we're at risk for fracture, if there's any falls, anything like that. We want to make sure that your bones are nice and strong. Your dietitian is going to make sure that you're getting enough calcium intake. We want to check to make sure that you have everything that you need. The dietary reference intakes vary by age. Our 4 to 8 year young children need about 1,000 milligrams a day, and that's probably about 3 servings of our dairy. We need, for 9 and older, 1,300 milligrams of calcium every day. So we cover those bases with about 4 servings of our dairy foods or fortified non-dairy substitutes. Now, dairy is most well known, but of course it doesn't have to be what we're going to be eating. But you can see we have much higher amounts of calcium available per serving compared to some other foods that carry our calcium with what we're going to be eating and how much calcium comes with it. Now, if your child's not eating any of these foods, what do? We can certainly supplement here, and this is where supplementation could be appropriate. This is something where I've had discussions with my children. Would you rather drink a cup of milk, or would you rather chew on your calcium supplement? And they get to make the choice here. So a lot of the calcium comes in 500 to 600 milligram supplemental forms. Your best bet, you want to spread your calcium out throughout the day to really optimize that absorption of the calcium. So with every meal, if we have some sort of calcium-rich food, that's great. If you are going to take a supplement because we're not meeting all those servings of calcium, have that at separate times from a dairy source, for example, so that we don't take all the calcium in at once. We're spreading it out to really help absorb it the best. But you can see there's lots of different food options that we have, and those supplements can be fairly tasty. There's some that I compare to Starburst. There's other supplements that are chocolate flavored. There's some that are on the more chalky side. So really, whichever one your child will be willing to take and eat. A lot of children will get sick of one and want to switch over to something else. That's absolutely fine, as long as we are meeting our mark and getting our calcium either through food or supplemental form, so that we can make sure those bones are getting the best that they need. Now, vitamin D is another very important nutrient. This is something that actually, when activated in our body, acts like a coach. And so with this is going to be very important to make sure we have enough. The DRI is about 600 international units, or 15 micrograms daily, but it's not uncommon to see our neuromuscular kids needing more. It is fortified in many different food sources. We check our children annually to see what their vitamin D levels look like. If they are going to be in need of supplementation because lab levels are low, it's actually one of the easiest supplements to take. You can get it in liquid form or chewable. Doesn't taste like anything. So kids rarely give any pushback when it comes to taking this as a supplement. Well, thank you all very much. Does anyone have any questions?
Awesome. Well, thank you so much, Kelly, for that amazing presentation. I'm just going to open the floor up now to any Q&A. So do feel free to type into the Q&A chat box, and I'll just give it a minute or two to wait for a question coming in. Alrighty, so I don't see any questions coming up, but this, just as a reminder, again, this will be recorded and is going to be posted on the MDA.org website. So if you do have a question about the presentation going forward, you can email mdaengage@mdausa.org. I just want to say thank you again, Kelly, for your amazing presentation, and thank you so much for all you do for the neuromuscular community.
Thank you as well. I hope you all have a wonderful day.
Okay, so I would now like to introduce our first speaker, Jennifer Jones. Jennifer Jones is a board-certified clinical specialist in pediatric physical therapy who works at the Children's Hospital of Philadelphia. She treats both as an outpatient physical therapist and a physical therapist in the neuromuscular program. Previously, she has volunteered as a camp counselor during MDA summer camp for 5 years. So thank you so much for joining us today, Jennifer, and I will go ahead and hand it off to you.
Great. Hi, everyone. Thank you so much for having me. Just bear with me as I bring up my slides for you. There we go. Okay, so I am very excited to talk to you guys a little bit about exercise today. So just a brief overview of the presentation. We're first going to go ahead, before getting into some tips and some different interventions, I'm going to go ahead and discuss the benefits of exercises in many age groups, talk about how this is specifically relevant to individuals with neuromuscular disease. I'm going to talk about something called the FIT principle, and then also discuss the different components of it. And then from there, talk about a couple different exercise interventions for individuals with neuromuscular disease. So I do have a little disclaimer. This presentation is for educational purposes and shouldn't replace any advice that's been provided by your medical team. It's just important to know that every different neuromuscular disease may respond just a little bit differently. So just as you're developing a new exercise program, it's also important to discuss the benefits and risks with your medical team. So what is exercise? I know this sounds like a simple question, but it is a little bit different of something that we would consider physical activity. So physical activity is something that's done from a day-to-day basis. So this is something that just more of your general bodily movement, where exercise is actually going to be more of a planned, structured, and repetitive motion. And I want to talk a little bit. So first I want to introduce what the ACSM is. So this is an American College of Sports Medicine, and this is actually our gold standard when we are providing exercise recommendations. So as you can see up on the screen, there's many benefits from a pretty wide range of ages. So anywhere from 3 to 50, as you can see on the screen, anywhere from cardiorespiratory, muscular fitness, body composition, and even looking at preventing hypertension, type 2 diabetes. And really, it seems that the key here is shooting for about 150 minutes per week. And while I know that sounds like a big number, this can be broken down into about 20 minutes per day. So let's look a little bit more specifically at why exercise is important with neuromuscular disease. So first, we want to maximize our function. The principle, use it or lose it, does come in play here, because if we're not using our muscles, the idea is that we potentially can get weaker quickly or develop contractures quicker. So we do want to, with exercise, minimize contractures and then also decrease weight gain. Both contractures and weight gain can actually are actually linked with function as well, which is why we want to maximize your function. The other reason it's important is we want to help maintain bone strength. We know that steroids are very common with many individuals with neuromuscular disease, and that can also be linked with osteopenia, where your muscles or your bones get a little bit weaker. So by doing exercise, this is actually something that can help combat that. Now, there are some things that we want to be a little bit cautious with when developing exercise. So thinking about eccentric strengthening and then also the type of intensity. And I'll go ahead and define those a little bit more in the presentation for you guys. So the FIT principle, this is something that's going to help you create like a workout plan. You're going to look at your frequency, your intensity, your time, and then also the type of exercise that you're doing. I'm going to start a little bit backwards here. So I'm actually starting with type. So we're going to look at strengthening, where you can be strengthening both your muscles and your bones, aerobic, where you're getting your heart rate up, and then flexibility, where you're stretching your muscles. So with strengthening, there's a couple different types. I'm going to define those a little bit more on our next slide. But then there's also a couple different techniques that you can use. So you can actually eliminate gravity and do strengthening without gravity. You can move against gravity, and then you can also use a little bit of resistance, which is typically done with some sort of weight or resistive bands. So when looking at the different types of strengthening, I'm actually going to use, I love cookies, so I'm going to use my cookie example. So isometric is if you put your palm up to the ceiling and you place a jar of cookies right on your palm. So we don't want that cookie jar to fall off or move off of your hand, so your joint is not moving. So this is what we would call an isometric muscle contraction. Concentric is when you're starting to move that cookie up to your mouth. So that's where your muscle is actually shortening. Eccentric, as I kind of talked a little bit about before, is where you're taking that cookie away from your mouth, and that's going to be where that muscle actually lengthens. So using our traffic light analogy, so green where you're good to go, typically neuromuscular diseases that involve more than nerves, like Charcot-Marie-Tooth, is okay to start an eccentric muscle strengthening program. Where we want to be a little bit more cautious is where those diagnoses that involve more than muscle membrane. So an example would be more of Duchenne muscular dystrophy. So there's many types of ways to do strengthening. Aquatics is a great way to do this. There's many benefits. So you can use the buoyancy of the water. So that's going to help minimize the effect of gravity. You can also use resistance and kind of tailor the resistance to you by using the drag of the water. So the quicker that you're moving your arm or your leg through the water can make a difference in terms of how hard it is. It's also great because you can use multiple different functional levels, can get in the pool and get benefit out of it. So you can see on the left side of the screen is for someone that is able to stand, there's a couple of different ways that you can move your legs around just to be able to start strengthening those leg muscles. You can also use a flotation device, or great in the pool, because it's going to give you a little bit more independence and be able to move easier in the pool without having help. I have like 2 different types of neck rings listed up on the screen, which are also great ways to move in the water. You can also do strengthening through slings and springs. So what slings and springs is that's really where your limb is suspended and then it's taking away the impact of gravity. So you're not really having that friction to worry about anymore. You can do this again. You can do this with multiple functional levels. In the picture, I have a PVC device set up, but you really can use anything where you can suspend bands and a cuff, where it has to be sturdy enough to support your limb. So in the pictures, I do have your legs, but it's also really great for arms as well. Aerobic. So this is where we're getting our heart rate up. So the ACSM definition is where we're using larger muscle groups, and then it's something that can be contained continuously and is more rhythmic. So it's very repetitive and that you're doing for a duration of time. 2 types of aerobic exercises that can be completed and that's safe in the neuromuscular population is in the water, and then also cycling. So I have a picture of an adapted bike up on the screen, which is really great because it can give you a little extra support if you want to be able to go outside. But then I also have an ergometer where you can place it on like a tabletop or even on the floor. So you'd be able to sit in your chair or your wheelchair and be able to use this. Flexibility. So this is looking at a different couple of ways. So passive range of motion is where you're having someone else move your limb through your available range of motion. Active range of motion, that's where you're moving your own body through its available range of motion. Active assisted range of motion is where you can help yourself move your limb through like the range of motion available. And then we have stretching. So stretching is important because contractures are very common in neuromuscular disease or diagnoses. So what you can do is go ahead and place your stretching is where you're actually placing your muscle in a lengthened position. And this can be done through static stretching where you're counting to about 20 or 30 seconds. And so this can be done by somebody else, or this can be done by yourself as well. There's also, you can get stretching through a principle called low load and prolonged stretching. And this is typically done through serial casting or night splints. And the other way that you're able to get full available range of motion is also by doing any type of standing or supported standing through like a stander. Okay, so frequency is the next part of our FIT principle. So looking at that's how frequently you're doing your exercises. So while we're looking at frequency, it is important that you do have rest days in your program. This is really going to allow you to be able to monitor and see your tolerance to your current program. So this is where you're going to know if you went a little bit too hard or if you need to push yourself a little bit more. Strengthening is recommended for about twice a week, bone strengthening at least twice a week, and then aerobic is 5 days a week. And this can be done cumulatively, but it also can, especially as you're first starting off, it can be split into like smaller sections throughout the day. Intensity. So how hard should I be working? Submaximal is what's recommended for the neuromuscular population. So this should be about light or moderate. So how do we know how hard we're working? There's a couple different ways that you can use to measure and see how hard you're working. The first way is rating of perceived effort, or RPE, where 0 is you're sitting and watching TV and really not doing too much. 10 is where you're working as hard as you can and you just can't possibly go any further. Talk test, so that's just looking at your ability to talk while you're doing exercise. And then you can even look more specifically at your heart rate by using a formula of 220 minus age. So I put together just like a little chart just to kind of help you figure out the difference between moderate and vigorous. An RPE of 3 to 4 is typically recommended as moderate. 5 to 7 is vigorous. Oh, and excuse me, I just have a little something in my throat. Talk test is where you can keep a steady conversation, and then at moderate, and then vigorous is where you're unable to speak more than a few words. Looking at your heart rate, you can use your formula by using like your watch or your chest strap, and then that's typically 64 to 76 is considered moderate, and 77 to 93 is vigorous. So how long and how much? Strengthening, we want to shoot for about 8 to 12 reps. For flexibility, we want to stay in the range of 20 to 30 seconds, but for that low load prolonged stretch, it's going to be a bit longer at about 6 hours. Aerobic, we're really shooting for about 150 minutes per week. And there are a couple of articles that for cycling are recommended about 30 minutes, 5 days a week. And that was including your warm up and cool down. So in conclusion, exercise has been shown to be safe, and it does appear that it is showing great benefits. It does need to be specific, so the program should be specific to your diagnosis and then also your functional level. We do want to incorporate it into your daily life and then also to make it fun, and the reason is this is something, in order to see some good results, it is something that needs to be done on a regular basis. And then in general, unfortunately, we really do need more research. For more specific guidelines. So it's all the protocols and literature are very variable, including the intensity and duration that is listed. And then just to file my references. And that's all I have for you guys. Thank you so much for listening to me.
Thank you so much, Jennifer, for that presentation. I'm going to open it up to a quick Q&A before I introduce our next speaker on this topic, Kim Anderson. So if there are any questions in the chat, I'll just leave a minute or two here to see if there's any questions coming in. And then if not, I'll go right into the next part of the presentation.
I think I went too vigorous on my presentation. I have something in my throat.
Awesome. Well, I don't see any questions in the chat, but again, for any audience members, if you do have a question that comes up after this presentation, you can email mdaengage@mdausa.org, and this will be recorded and put on our website. So again, thank you so much, Jennifer, for your presentation. We really appreciate all you do for the neuromuscular community.
Thank you, everyone. I appreciate it.
Awesome. All right, and now I'm going to introduce our next speaker. So our next speaker is going to be Kim Anderson. Kim Anderson has been an occupational therapist at the Children's Hospital of Philadelphia since 2012 and a pediatric therapist since 2008. She provides outpatient-based therapy services, interdisciplinary specialty clinic consultations and evaluations, and participates in clinical research. Her specialty practice includes the use of splinting and dynamic movement orthosis for patients with neuromuscular diagnoses. Kim specializes in aquatic therapy for children with a variety of medical diagnoses, including neuromuscular diagnosis, brachial plexus injuries, and hemiplegia. She leads an aquatic therapy group for caregivers and patients with spinal muscular atrophy. Thank you so much for being with us today, Kim. And I'm going to go ahead and give it off to you.
Okay, great. Thanks, Kristen. I'm sorry, I'm not able to get the video to work on the screen here. Can you hear me?
Yes, we can hear you.
Okay, great. Let me get the share screen here. All right, are you able to see my presentation?
Not currently.
Okay, sorry about that.
Here.
Oops. Try again. Okay, I think it says I'm sharing my screen. I'm not sure.
We aren't able to see it up on the screen right now, but we can definitely try to pull up our secondary slides for you if that works.
I'm sorry, Kristen, can you see it now, or I will need you to present the PowerPoint?
We're not able to see it right now, but I will go ahead and find the PowerPoint and share my own screen.
I'm sorry, thank you.
Kim, are you able to see the screen shared right now?
Yes, I can.
Perfect. Is this going to work for you?
Yeah, if it does for you, I apologize. I don't know why my thing isn't working.
Great, no worries at all.
Okay, well, first of all, thank you for the MDA for putting on such a great event. My name is Kim Anderson, and I'm going to talk to you today about everyday tips for activities of daily living. I have no financial disclosures. And the objectives of this presentation today are, I'm going to review with you the advances in adaptive clothing options. We'll talk a little bit about adaptations to assist with completion of ADLs, and then just reviewing some technology within the home that can help with independence. So first, I wanted to give my own profession a little plug here. With all the options that are available these days, it's great that there are so many, but a lot can be overwhelming and can also become expensive, especially if you're not sure what you need. So as an occupational therapist, we are able to help you identify your own strengths and needs. We help you identify and prioritize which specific ADL goals you have, and then help you to identify what adaptations will work best for you for your own specific individual needs. So this next slide, when I first started doing this presentation, probably like five or 6 years ago, we maybe had 2 or 3 things to put on the page. And these are just a few of what's available now. I wasn't even able to fit everything on here. And you can see there's a lot of familiar mainstream clothing companies that are now providing adaptive clothing. So first, one of the main things that a lot of these companies are providing are magnetic and Velcro closures instead of having the button and zippers and snaps. This is perfect for our patients who have distal motor function issues, fine motor delays or weaknesses, or if they have distal contractures. You can see our friend here on the left, he has a Velcro opening on the left leg that can help if you were to need a brace on that side. And then the right side has a shorter pant leg to be able to easily access his device that he needs for the right. The next picture to the right, you can see the Tommy Hilfiger jeans are taking away the zipper and those hard to button buttons altogether. And as soon as you match up the clothing, the magnets will come together and the Velcro comes together, but it still looks like there's a button and zipper from the front. So it looks still like mainstream clothing. For the top right here, a lot of our teenage girls are experiencing difficulties with being able to latch their bra both in the back or in the front and being able to turn it around. So a few of those companies on that slide that we just showed are providing now sports bras and regular bras that have both magnetic and Velcro closures for ease of use. And then this bottom right is actually a company that I found on Etsy. So for our patients that maybe have some lower extremity weakness, these dress pants still have the appearance of being dress pants on the front, and they are dress pants, but they actually zip or Velcro or have magnetic closures on the side. So maybe like while you're getting dressed with sitting down or laying down, you can put them on that way and then zip them up on the side rather than having to lace your legs through the bottom. Next slide. This company here does, on the right, sorry, using strategically placed loops to help some of our friends that have maybe those similar situations of distal weakness or finger contractures, wrist contractures. So you're able to position your hands through the loops so that can help you with pulling the clothing items up or down rather than relying on that pinch that's typically used. And they make clothing from toddler all the way up to adult. So it's been great for a wide variety of our patients. And then one of the types of clothing that is sometimes missed is compression. There are some patients, like with hypotonia or hypermobility that have some lack of body awareness and attention issues. So sometimes we will recommend compression clothing, and up until more recently, we would have to recommend like an Under Armour or like a swim type shirt clothing or pants. Whereas now there's more companies delving into compression, so the items can look more mainstream, as you can see in this picture here to the right. Next slide, please. Okay, so shoes now are, there's more and more companies that are providing the zip option for a wider opening. You can see here the Billy Footwear and Nike are both diving into this realm. So patients who have devices that they may need to wear on both feet or one foot are able to use these shoes for ease of getting them on and off. And I can tell you the two companies that I know, Nordstrom and Zappos, both offer the option of if you are wearing a brace only on one side, you can have the option of buying a single pair of shoes that are two different sizes in case you need to size up on one side. The top right Nike sneaker here doesn't have any type of tie closure at all. All you need to do is position your toe and slip your foot in, and the shoe closes. And all you need is a little pressure on the back heel with lifting up of the foot to take your foot out of the shoe. In the bottom right here, the Hickeys is just one company that we typically will recommend. You can pre-lace these into your typically tied shoes and turn your tie shoe into a slip-on. So if you're a person who has a particular shoe that you like the Brooks or Nike or any kind of tie shoes, Hickeys is a great company because they have lots of different colors and designs that you can use to turn your shoe into a slip-on. I don't really recommend this for anyone who has a brace because it will make it harder to put on, but anyone who's just having difficulty with the tie and wants a slip-on, those are great options. This slide here, I figured, since we're next week coming into the Halloween holiday, it was great seeing more websites that provided Halloween costume options with similar adaptive clothing styles and even adapted to the wheelchair. So Kohl's, Target, and Disney were the main ones that I found, and for pretty cheap prices. So it's just great to see such a widespread here. Next slide. So a couple other clothing fasteners. You can see the belt at the top here. Latching a belt can be extremely difficult for someone who has a sensory neuropathy or distal contractures or just a fine motor weakness. And here we are using the Velcro technology to still have the appearance of the latch belt, especially for like work or dress uniform clothes. On the bottom, the mag zip, a lot of our patients love this. You can buy just the zipper itself, and if you're a sewer, you can adapt it to the clothing that you already have. If you're like me and you're not, Under Armour has a line of these sweatshirts, and Etsy also has a few shops that provide clothing options with this magnetic technology. The two sides just line up and latch together using magnets, so you don't have to worry about the latch. And then you can just pull the zipper right up. Next slide, please. So for feeding and grooming, this cup with the straw is pretty familiar. It's a flexi straw that's long, so a caregiver can set up the cup into a position for someone who has lack of upper body movement so that they're able to access the straw themselves with independence. The vibrating toothbrush is a good option for our patients that don't have the strength to really use the force to brush their teeth. So the vibration helps with that. The plate guide helps with getting the food onto the utensils for those that have trouble spearing their food or scooping. And this picture to the right is a company called Easy Hold. You can see they sell, it's a silicone universal cuff that you can put on, as you can see, a hairbrush, utensils, pencil, really anything that you can use a universal cuff with. Okay, next slide, please. So for this, I just thought I would show this fun snack cup here. A lot of mainstream typical snack cups for kiddos have the harder plastic with the slots where the kids have to push their hand through really and have a good grasp to then bring the food back out through that resistance. And this cup here, you can see, if you could play the video, sorry. I wonder if it's gonna work.
I don't think the video is able to play.
Okay. So if you were to see the video, the cup can be turned in multiple different directions without spilling and still have the open surface for the patient to access. So if you have to hold it in a certain position due to contractures or weakness, then the bowl is still open to retrieve the snack from with ease without having that hard plastic to work through. Okay. And next we have something that's called the liftware level. I apologize, the video probably won't work, but this gentleman does a great job of demonstrating how the spoon is able to stay level no matter what direction he's holding it in. So I'll describe, like, this patient, or this gentleman, sorry, is going to scoop his breakfast, and he's really testing it out, twirling the spoon all around in different directions with the yogurt on there. And never spills it. And you can see it also still has a universal cuff option. So if you have that lack of grasp, or you don't really have the supination to achieve bringing the spoon to your mouth, the spoon is able to kind of adjust to what you need. And it's battery powered, so it adjusts as you need it. Go ahead to the next slide. Okay, this device is called the Obi device. I apologize, there's a video here. What it does is it uses a switch system, 2 switches. You can set the spoon up when you start the meal to meet your mouth to where you're sitting. And then 1 switch you click to pick at 1 out of the 4 bowls to eat from. and then the other switch will bring the food to your mouth. It doesn't necessarily have to be like a typical switch that you can think of like the button switches, and it can also be hooked up to your phone for voice activation. You can see the picture on the left. The little boy is just mainstream sitting in with his classmates, not having to be fed by an adult. And it's been a huge game changer for some of our little ones in just building independence in a social setting too. Okay, next for meal prep. A lot of our little ones don't do a lot of meal prep, but for if they were to get a bowl of cereal or a drink from the refrigerator, we will recommend getting the Magic Tap. So you won't have to lift the large gallon of milk out of the refrigerator. We're thinking about the rest of the family. A lot of our families were going out and buying smaller things of milk so that our patients could access it. And here, all you have to do is put the cup or bowl up to this lever here, and the milk or whatever liquid you have in that container can easily come out. The bottom left here, someone combined the technology of using the pizza cutter and the rocker knife. And you can use the same cutting strategy with less gross grasp, and it does put a lot of its own pressure on there, so for more independence in that way. Next slide. So for showering, typically, depending on your needs, we will recommend a handheld shower head. Pump top and automatic soap dispensers can also make things easier. Using a shower mitt, so just slipping a shower mitt over your hand if you're having difficulty holding on to a washcloth. And then handles can not only be helpful for safety with getting in and out, but we will sometimes recommend for our patients who have a hard time achieving their hands to their head and sustaining it for long enough to get the soap out. You can put a handle horizontal to prop your elbows on to sustain that position for long enough for hair washing. Next, please. So in the OT world, we're not only adapting the activity for the patient, but we can also adapt the patient to the activity. So for some of our patients who are a little bit weaker in their upper body, we will use a mobile arm support that uses suspension to help the patient increase their active range. It helps with positioning depending on the task. It reduces the amount of unsafe posturing, so that leaning forward or moving their trunk around in order to achieve a hand to the mouth for self-feeding, for instance, or brushing teeth. And the next slide here are a couple of videos. I apologize, I'll send the slide back out to the MDA so that they can have the videos too. The left video was one of our friends. He's got good elbow flexion extension, but doesn't have much movement at the shoulder, and he does a lot of dance moves with his trunk and his head to try to achieve his hand to his mouth. And then the picture or the video on the right is him in the arm support device. And he's got a lot more dance moves with his arm. He's able to easily achieve his hand to his mouth for brushing teeth, washing his face. Some people use it for glasses adjustment, things like that, that some of us take for granted, you know, like not having to ask anyone to do that for us. This device can also be used, as Jen was describing before, with exercise for our patients who are also working on strengthening. Once they're positioned in this device, they can do those movements to help with active movement for video games and other things like that. Okay, next slide. Adaptive technology. As you can see, technology is not my strong point here, as I cannot get my video working or my slideshow. But we do have a great group of OTs here that we send our neuromuscular population to, and they can do a specific assistive technology evaluation. But a lot of our patients do report that they love this Microsoft Xbox Switch system, where they can play the same games that their friends do using the adaptive switches. Next slide. Smart home technology. I won't say the name out loud because if you're watching, it'll probably set the devices off. But the Amazon and Google seem to be the most popular, where you can use your voice activation and you can really access a lot of things within the home. So door locks, opening and closing doors, ceiling fans, opening and closing blinds, the thermostat, the TV. A lot of different things can all be accessed with your voice or with switch technology. Let me go to the next slide here. And this is just an example of one of the switches that we were able to use. So this is the example. We used the same switch technology with a teenage patient who had SMA and a little bit of thumb flexion. We hooked it up to a speech device where with the clicks, he was able to spell out words to say to his Alexa. And I think he was 19 or 20. And at that age, his family learned that he liked a certain type of cartoon show and he loved country music, and they never knew that about him because now he was able to speak through this switch technology, and not even to tell his parents what to do, but the Alexa was able to access that for him. And this is just a quick review on how you can make your own switch. I do have directions if you're looking for that too. You can make switch things at home. You can adapt toys, or like we talked about, the switch technology for talking to the Alexa to access the home environment or video games. And then the last slide here. We're very lucky in the state of Pennsylvania that we get to work closely with TechOwl. It's a company that's supported by the state, and TechOwl is able to provide assistive technology for anyone within the state of Pennsylvania for whatever your needs may be, anywhere from building a PVC pipe chair to access a beach to developing 3D technology for a key holder or other things like that. And I did have a video here. They are on TikTok. I don't know if some of our viewers here use TikTok, but if you look up TechOwl, they have some great technology suggestions, and I'm sure they would be willing to help you with any of your needs, even if you are not in the state of Pennsylvania. Okay, that was it. Does anyone have any questions?
Well, thank you so much for that amazing presentation. I apologize that you weren't able to share some of those videos. If you'd like to send your PowerPoint slides to MDA so that we're able to share that with the community, that would be great. I'm just going to open up the Q&A and just wait a moment or two for any questions that come into the chat box. All right, so it's looking like we don't have any questions at the moment, but this will be recorded and posted on mda.org. So if you do have any questions about this particular presentation, you can email mdaengage@mdausa.org. I want to thank you again, Kim and Jennifer, for presenting on everyday tips for exercise, adaptive clothing, and self-care. We really appreciate all you do for MDA and for the neuromuscular community. So thank you again for your presentation today.
Thank you so much. Thanks for your help too.
Awesome. And our next speaker will be presenting at 3:00 p.m. Eastern Standard Time. Dr. Michelle Caraballo will be presenting on respiratory implications in children. So we do have quite a bit of a break right now. So we are just going to take a pause for about 35 minutes, and then we will reconvene around 3:55 p.m. for the next speaker. Okay, and welcome back to the MDA Engage Pediatric Neuromuscular Care Seminar. I would now like to introduce our last speaker for the day, Dr. Michelle Caraballo. Dr. Caraballo is a pediatric pulmonologist and sleep medicine specialist at Children's Health and an assistant professor of pediatrics at the University of Texas Southwestern Medical Center. After receiving her Bachelor of Science in Bioengineering from Rice University, she completed medical school and pediatric residency at UT Southwestern in Dallas. She then did fellowships in both pediatric pulmonology and sleep medicine at the University of Colorado in Denver before returning as faculty at UT Southwestern in 2015. In addition to her pulmonary and sleep medicine clinics, as well as inpatient rounds for children on the pulmonology service, she helps run a monthly Duchenne muscular dystrophy multidisciplinary care clinic, which includes specialists from pulmonology, neurology, cardiology, and an ancillary support from physical therapy, dietitians, and social work. Outside of work, Dr. Caraballo's favorite hobbies are baking and spending time with her husband and her 2 young sons. And with that, I will go ahead and hand it over to you. Thank you so much for participating today, Dr. Caraballo.
Thank you for having me. Can you hear me okay?
Yep.
Great. I was just so honored to be invited to spend this time with y'all this afternoon and talk about this topic that I'm very passionate about. I see we have a small group, so I'm happy to make this as informal as possible. If you have a question in the middle of a slide and you want to unmute and ask, I'm more than happy to try to address it. And I know I'm the last speaker of the day, so I'll try to make it quick so everyone can move on with their Saturday. Let me share my screen here. Okay, let me know if that doesn't look okay. Hopefully you can see that.
Looks perfect.
Great, thank you. So just as an introduction, you know, the respiratory complications that we see in children with neuromuscular disease are not because the lungs themselves are bad or are weak, but it's because the muscles that help with breathing and cough and all of those things become weaker over time. So these children tend to experience a very predictable progressive weakness of the respiratory muscles, which over time can lead to difficulty taking deep breaths and coughing effectively. Oftentimes the first signs of difficulty breathing we see appear during sleep, and as the muscle weakness progresses, daytime breathing difficulties appear as well. The age and severity of these symptoms depends heavily on what type of neuromuscular disease patients have, but this is an expected progression with various types of neuromuscular disease. So the normal cough involves basically 3 stages that allow us to expel mucus from our lungs. So a normal cough starts with this very deep inspiration, deep breath that opens up the airways, increases the amount of air in your lungs, and this allows for a higher speed of expulsion of that air, so coughing that air out. Very, very briefly, the muscles of the mouth and throat, called bulbar muscles, will kind of contract and close the upper airway just for a split second, while the expiratory muscles, so the muscles that help expel the mucus, contract. And this increases pressure in the chest to allow you to blow that air out at high flow rates. Children with neuromuscular disease can experience weakness of all of the muscles involved in this normal cough process. And so the various muscle weakness impairs the different stages of the normal cough. Weakness of the inspiratory muscles will limit the deep breath that precedes the cough. Weakness of the throat or mouth muscles we talked about that help close the upper airway, those are called bulbar muscles. So bulbar muscle weakness will impair the compression portion of the cough, where the pressure in your chest cavity or your thorax increases. And then weakness of the expiratory muscles makes it hard to expel air at a high flow rate, so diminishes the speed of the expiratory air. This is a snapshot of pulmonary function tests that we do routinely in all kids who are over the age of 5 in our clinic. And the reason that we don't do them under the age of 5 is just because usually developmentally they're not able to understand the concept of the testing. But we routinely do these tests every time the patient comes to the office, and it gives us an idea of how effective their cough strength is, how good their lung volumes are, how well they can take a deep breath in, blow out hard, and all of those things. So we know that viral respiratory illness can cause a temporary reduction in respiratory muscle strength in anybody, not just children with neuromuscular disease, but your muscles can get weaker during illness. And one of the main measures we look at, specifically in neuromuscular disease, is this parameter called CPEF, which is at the top here with this red arrow. CPEF stands for cough peak expiratory flow. And that gives me an idea of how strong their cough strength is. And there's pretty well-defined data in the medical literature that suggests that when this number drops below 270, that's when we should start techniques or order equipment for patients to help with their cough. Now, this 270 number is defined mainly for adolescents and adults. Kids, we would expect to have a lower cough strength, just because, of course, a 5-year-old's not going to have as strong of muscles as a grown man, right? So we would expect younger children to have lower cough peak flows anyway. One of the other markers of expiratory muscle strength we look at here are called the MEP and the MIP. So MEP here at the bottom stands for maximal expiratory pressure. MIP stands for maximal inspiratory pressure, and that's looking at how hard a child can suck in for the inspiratory part and can blow out for the expiratory part. And you can see across the board here, we have the second column here that says PRED. These are the predicted values. And these numbers are based on a child's age and gender and height. So they say, how much air would we expect an average child of this age to be able to blow out or suck in? And how do their numbers compare to these predicted values? So these are the predicted numbers here in the second column, and you can see this fourth column here is what this patient actually blew out, and then this is the percent predicted. So you can see this patient here has pretty good muscle strength. Their maximal expiratory pressure is 83% of the predicted value, which is we would consider within normal, above 80% of the expected number. Their maximal inspiratory pressure is above average for a child their age and height. So this child has pretty preserved expiratory and inspiratory muscle strength. But these are the main numbers I'm looking at when they come into the office to help me understand how strong their cough is and whether or not they may need assistance with their cough. As we talked briefly earlier, younger children are expected to have lower cough peak flows than older adolescents or adults. The normal values will vary with age and height, and there are very few normative data in children, meaning we don't know for sure what a normal cough peak flow is for a 6-year-old or an 8-year-old or a 10-year-old. The best data we have are for adults. So we use that 270 cutoff that I mentioned for adults and adolescents, but what's considered normal in a younger child is not widely accepted or known. So the best indication in younger kids for whether they need assistance with their cough is really whether they have a subjectively weak cough. So I will ask the parents, when your child is sick, do you feel like they can have a good strong cough and able to clear mucus from their throat or their lungs if they need to? And I will often ask the kids to cough for me in the office. I'll say, can you just show me how strong you can cough? And, put their mouth into their elbow and really hard. And that gives me some idea of how strong their cough is as well. And then certainly any child that has a history of frequent respiratory illnesses or pneumonias, that's likely to be a child that has impaired respiratory muscle or cough strength and probably needs assistance with their cough. Atelectasis is another common respiratory complication of neuromuscular disease. This is just a medical term that means either partial or complete collapse of parts of the lung. And it's caused by like a deflation or collapse of the tiny little air sacs, like microscopic air sacs that participate in moving oxygen in and carbon dioxide out of the bloodstream. And these little air sacs are called alveoli. And we can develop collapse or deflation of these air sacs during illness, but it can also happen because of shallow breathing over time when the respiratory muscles are weak. And it can involve anywhere from a very small part of one lung to a whole lobe of a lung or even an entire lung. And that's what I tried to show on these 3 x-rays here. If you've never looked at an x-ray before, what we're looking at here is the patients are facing the screen. So their right lung is shown on the left portion of the image and their left lung is shown on the right portion of the image. It's inverted. And on x-rays, air appears black. So the lungs should be mostly dark gray or black because they're full of air, of course. We all have a little bit of this kind of white streaky markings in our lungs, our blood vessels in our lungs, and that's normal. But when we see too much white in the lungs, that can suggest atelectasis. That can also be caused by mucus or fluid in the lungs. But this first image here is a patient that has just, you can see a little bit of increased white markings in the bottom part of the right lung here. The second image, this patient has atelectasis of the entire right upper lobe, and you can see it's a pretty well-defined line here. That's where the right upper lobe ends. And then the patient on the right has the atelectasis of their entire right lung. And this is not an uncommon finding in a patient with neuromuscular disease when they're sick. Another complication we like to look for and ask about in these patients is a difficulty with swallowing. And this is caused by weakness of the muscles that coordinate chewing and swallowing. And if these muscles are weak, what can happen is that microscopic tiny amounts of fluid or food particles can go down the wrong pipe into the lungs instead of into the stomach. And this little image is showing how the esophagus, which is the tube that carries food down to the stomach, and the trachea, which is the tube that carries air to the lungs, they sit right next to each other in the throat. And your vocal cords are what kind of separate them up here. But you could see how in a patient with swallowing weakness or difficulty with those muscles that it wouldn't be too difficult for little bits of food to accidentally go down the wrong pipe into the lungs here. And that's what's shown in the second image where the food enters the trachea by mistake. It's not usually large amounts of food like this. It's usually very, very small parts, but over the long term that can cause irritation of the airways and inflammation of the airways and predisposes these kids to illness and increased mucus production. If they do have a big chunk like this or a significant amount of food or liquid go down the wrong pipe into the lungs, that can cause a pneumonia. And you may have heard the term aspiration pneumonia before. And again, aspiration is just the medical term for food or liquid going down the wrong pipe into the lungs. Another complication that some children with neuromuscular disease develop is scoliosis over time. And this is again caused by weakness of the muscles in the chest and thorax that don't support their rib cage effectively, so that over time the rib cage starts to shift and the spine starts to shift and they develop scoliosis. I pulled these images. This is a very dramatic case of scoliosis. It's not often that severe, but it develops gradually over time. And it's not hard to imagine how this could affect the lungs, right? Because this child is very hunched over to one side. So one of the lungs becomes kind of compressed, and that causes collapse of those alveoli, or what we call atelectasis, and can cause them to have difficulty clearing mucus from their lungs. So let's shift to talk about what techniques and strategies and equipment we have to help these kids when they do have trouble clearing mucus from their lungs, what we call airway clearance. What do we have to help them with that? So this is kind of an old school technique that we don't use very often anymore because we have more advanced equipment to help with the cough these days. But this is what we would call a manually assisted cough that a nurse or a caregiver could do if the child doesn't have any equipment at home. It's almost kind of like a Heimlich maneuver. It's just a way to help the child expulse air from their lungs. So you can see this caregiver has put one hand on top of the other and placed it right below the top of the abdomen or the bottom of the rib cage. And when the person coughs, she will press in synchrony with their own cough, and it just helps with the expiratory muscle effort to help expel mucus. Now we have much fancier techniques to do basically the same thing, but we have equipment that will do this for you. This is called a mechanical insufflation-exsufflation, more commonly known as cough assist. And the term insufflation just means inflating the lungs or putting air into the lungs. Exsufflation just means exhalation or bringing air out of the lungs. And so the cough assist is exactly what it sounds like. It's this machine that helps the patient cough or helps simulate a cough by inflating their lungs, and then the machine can suck the air back out with a negative pressure. And I think it'll make a little more sense on the next page. So this machine has a soft little plastic mask that goes around the mouth and nose, and it creates a seal here. And you can see there's tubing that connects it to the little box. And basically it's just a puff of air in and then a suck back out. So it's like, psh. And we have these patients usually we have well settings and sick settings. So when they're well and they don't have mucus in their lungs, we'll just have them use the inspiratory part of the cycle to help expand the lungs and help them take really deep breaths. And then when they're sick, they can flip a switch and it switches to the sick settings, and they use the inspiratory and the expiratory cycle. So the puff of air in to help expand the lungs, and then the pulling it out to help with the cough and pulling mucus out. And I just put this example here. This is kind of our standard prescription for our patients with neuromuscular disease. And your physician or your respiratory therapist can set these settings on the machine, but we'll set the pressure somewhere between 20 and 40 centimeters of water. You can set the inspiratory time. So that means, here we have 2 seconds. So that means over 2 seconds, the machine will inflate that much pressure into the lungs and then pause 2 seconds. And then when they're sick, we also add the expiratory time. So expiratory time is 2 seconds. And we tell them to do 3 sets of 5 breaths twice a day. So they'll do 5 breaths and then take a break, and then 5 more breaths and then take a break, and then 5 more breaths. So a total of 15 breaths in the morning, 15 breaths at night. And again, when they're well, just the inspiratory cycle to help expand the lungs, and then we add the expiratory part when they're sick. What about how do we mobilize secretion? So that means when you get sick and you have mucus in your lungs, that mucus can kind of dwell and settle down in the lower part of your airways. And we want to help people move that to get it towards the center or bigger part of their lungs where they can cough it out more easily. Or if you have a suction machine, it may be easier to suck it out with the suction machine. So there's a few different techniques for this. This one is called IPV, which stands for intrapulmonary percussive ventilation. These 3 devices are all different IPV machines. The red one is the one designed for hospital use only. So I would suspect most people don't have this at home, but you may see it in the hospital. The green one is the older model that was designed for home use. And then this blue one is the newest, fanciest bells and whistles designed for home use. So what this does, it has a little mouthpiece that the patient can hold in their mouth, and they create a seal around it with their lips. And it just sends these quick, small bursts of air to help open up the airways, and those vibrations can help kind of loosen the secretions and help get them out. So it's more just like a ch-ch-ch-ch. So it's much faster versus the cough assist, which is a full 2 seconds of air in. And the goal here is to, again, move the secretions from the more distal or the outside peripheral parts of their lungs to their central airways, where it'd be easier for them to cough it out or suction it out. You do have to have a patient who can understand the concept of creating a seal around the mouthpiece, and they have to hold their cheeks tight, because otherwise with the puffs of air, they just puff their cheeks out every time like a chipmunk, and that doesn't do the patient any good. We of course need that air to get delivered down to the lower parts of their airways, as opposed to every time there's a puff of air in, their cheeks just like that, which is not very effective. One of the benefits of this machine, you can deliver nebulized medications through this machine. So if your doctor has prescribed albuterol treatments or any other form of nebulized medication, it can be delivered through the IPV. And this can also be given through a tracheostomy for the patients that have a tracheostomy, which is the surgical procedure where they put the tube in the neck to help patients breathe. This is a device called a vest, and its job is high frequency chest wall oscillations, more commonly known as vest. So what this does is, you can see the tubes here that connect to the machine, and the tubes send small amounts of air that very, very rapidly inflate and deflate the vest, like 20 times a second. So very rapidly inflate and deflate the vest, and the result is these vibrations that help loosen the mucus in the lungs. And typically I have patients do this. If they need it, we'll do like 15 minutes twice a day or something like that. So the job is to help, again, the vibrations help separate the mucus from the walls of the airway, help loosen it out, again, where it can be more easily suctioned or coughed out. Most patients that I have prescribed vests for really like their vests. It's very well tolerated. It's almost like a little massage. I have some patients that tell me their kids will, or the parents tell me that their kids will ask for their vest treatments because they like it so much. So it's generally very well tolerated, as opposed to, if I'm being perfectly transparent, most people don't like their cough assist. It's not a very pleasant sensation to have that big puff of air be forced into your lungs. So sometimes if we have patients that have trouble tolerating their cough assist, what we can do is, for example, turn down the pressures on the machine to help them kind of just practice with it and acclimate to it, with the eventual goal of turning those pressures back up, because of course if the pressures are too low, it won't be as effective in helping inflate the lungs or expelling the mucus with the expiratory cycle. This I stole from an article that was published in 2017, just to give a rough estimate of how much these devices cost. As you can see, they're pretty expensive to buy. Luckily, they're generally well covered by most insurances, especially for kids with a diagnosis of neuromuscular disease. We don't have trouble getting it covered for that indication. Cough assist is usually the first thing I order, which is the top one here, MI-E, which is the mechanical insufflation, exsufflation. That's the cough assist. That's usually the first thing I order for kids when we have signs of their cough strength getting weaker. Vests, I typically don't order until they are having trouble, like recurrent pneumonias and that kind of thing. But typically we just start with the cough assist. And I want to order the cough assist before they're having issues, right? When I see that their cough strength is weaker on their pulmonary function testing when they come into the office, I'm going to go ahead and order that child a cough assist, even if they've never had pneumonia before, because the goal, of course, is to stave that off as long as possible, to put off those potential complications, the respiratory complications of neuromuscular disease. I don't want to wait until they're having issues and then order the equipment, because by then we're already behind the 8 ball. You know, the goal is to keep them as healthy as possible for as long as possible. And what about medications to improve clearance of the mucus or control of their oral secretions? Now, I just have one slide on this, and I'm going to touch on it briefly with the disclaimer that none of these medicines have been shown in clinical studies to be effective for patients with neuromuscular disease. And when I say effective, I mean none of them have been shown necessarily to reduce frequency of pneumonia, reduce hospitalizations, prolong life expectancy, that kind of thing. Now, just because they haven't been proven in clinical trials to help doesn't mean that they don't help. It just means that those trials have not been done in large enough scale or large enough numbers of patients to really be able to find these differences. So again, it doesn't mean that they're not useful medicines. It just means they haven't been shown in any major clinical trials to be helpful. And for that reason, they're really not part of any of the clinical practice guidelines for taking care of children with neuromuscular disease. But I do sometimes prescribe them in individual patients on a case-by-case basis, kind of depending on what type of issues they're having. You know, if they have underlying asthma, if they've had recurrent pneumonias, that would be a reason to start some of these medicines. So the 4 main categories on this chart here, the top one is a class of medicines called expectorants, and its job is to help with mucus hydration. So for example, hypertonic saline is a more concentrated form of saline, but because it's salt water, it kind of hydrates those secretions and can help thin them out so that the child can cough them up more easily. It's also, because it's so concentrated, this form of saline is very concentrated, it can irritate the airways and induce a cough, can cause the child to cough, which is a good thing in these cases where we're trying to get them to clear mucus. Sometimes I have parents that say, I don't like hypertonic saline because it makes my kid cough. And I'm like, I know, but that's the point of it. That's what we want it to do, is make your child cough when they're sick to help clear their mucus. The second category here, called mucokinetics, the most commonly known example of this is albuterol. What albuterol does in neuromuscular disease, the reason we use it in neuromuscular disease would be different in patients with asthma, for example, which is the most common indication for albuterol is with asthma. But what it does for neuromuscular disease is that albuterol, in addition to, I don't know if you can see my hands on the camera here, in addition to opening up the airways like this, in our airways we have these very tiny microscopic hair-like things in our airways that beat like this. They're called cilia. And they're lining all along the airways. And what albuterol does is it makes these cilia beat faster. And so it can help transport mucus and move it upwards to cough it out more effectively because it increases the frequency of the cilia beating. It also helps open airways, but that's not the main reason we use it in cases like this. The third category of medicine is called mucolytics. Most common example of this is Dornase, and also known as Pulmozyme. The brand name is Pulmozyme. Its job is to kind of thin out secretions by decreasing what they call the viscosity, which is like the thickness or the stickiness of it, and it breaks certain types of bonds in the DNA on a molecular level. This has really only been shown to be effective in patients with cystic fibrosis, so we use it very infrequently in patients with neuromuscular disease, but it's something that, you know, if we have a child in the hospital with pneumonia and they're just not getting better, this is something we might try just to see if it would help. And then the fourth category here called mucoregulators. These are medicines that help dry up secretions, so they decrease mucus production. And they're all in this category of medicines called anticholinergics. And the most commonly known, ipratropium is also known as Atrovent. Atrovent's the brand name. Ipratropium is the generic name. Glycopyrrolate is another very common one. The brand names there are Couposa and Robinol. And again, their job is to help decrease mucus production. So this is helpful in kids who they may drool a lot, for example, because they have trouble swallowing and processing their saliva normally. So their saliva just kind of pools in the back of their throat and they can choke on it. And so we may use medicines like this to help dry up that saliva. All right, moving on to talk about sleep problems in children with neuromuscular disease. Normal sleep is associated with some physiologic changes, and that includes a decreased response to low oxygen levels, and the medical term for low oxygen levels is hypoxemia, and high carbon dioxide levels, the medical term for that is hypercapnia in sleep compared to wakefulness. And what that means is, you know, when I'm sitting here wide awake, if for some reason my oxygen level started to drop, my body would compensate for that by breathing harder and deeper and faster to try to breathe in more oxygen and bring my oxygen level back up. And that natural response, that normal response to low oxygen levels is kind of blunted in sleep in everyone. Our little on a microscopic level, our receptors that sense those changes are just not as responsive during sleep compared to wakefulness. We also lose muscle tone during a certain stage of sleep called REM sleep, which stands for rapid eye movement sleep. This is the stage of sleep that we dream in, and we all lose muscle tone during REM sleep. So these are kids who are oftentimes already weak at baseline, and then they go into REM and their muscles become even weaker, and it can contribute to more breathing difficulty. And furthermore, our breathing tends to be shallower in sleep in terms of how much volume of air we move in and out with each breath, is shallower in sleep than it is during wakefulness. And again, that's in everybody, in normal people. So what about in patients with neuromuscular disease? We know that neuromuscular weakness can kind of magnify or make these alterations in breathing that occur during sleep can be even worse in patients with neuromuscular disease than patients without neuromuscular disease. And this can lead to significant problems with gas exchange. And gas exchange just simply means oxygen in and carbon dioxide out. That's all we mean by gas exchange. That's the whole job of breathing. And these problems tend to get worse during REM sleep, like we mentioned, again, because of the muscle weakness, the loss of muscle tone we have during REM sleep. Kids who have scoliosis or are obese, this can even worsen these problems further just because the way their thorax curves with the scoliosis can make it harder for them to get oxygen in and carbon dioxide out. And then there are certain neuromuscular conditions that have other physical changes of the upper airway that can also contribute to obstruction of breathing during sleep. So for example, some conditions, patients are more likely to have a very large tongue, and the medical term for this is called macroglossia, or they may have a smaller or kind of recessed lower jaw, which is called retrognathia. And anything like that can kind of impinge on the airway or obstruct the airflow through the nose and the back of the throat can lead to higher risk of obstructive sleep apnea and can lead to more difficulty moving oxygen in and carbon dioxide out. So the sleep problems we see in children with neuromuscular disease can include obstructive sleep apnea, also, like we said, low oxygen or high carbon dioxide levels. They also tend to have very frequent arousals in sleep and fragmented sleep, and that means we can see on their brain waves, even for a few seconds at a time, they may wake up when we see awake brain waves, and that leads to just really poor sleep quality from the sleep fragmentation throughout the night. And to some extent, these arousals in sleep are a very healthy response to low oxygen or high carbon dioxide levels, because when the oxygen level starts to drop or the carbon dioxide level gets too high, the brain can sense that and it will wake the patient up. It'll kind of have an arousal, because when you're awake, that is more likely to restore normal breathing and bring your oxygen level back up to where it's supposed to be. So these arousals are a protective mechanism to help restore normal oxygen and carbon dioxide levels, but it contributes to really poor sleep quality in these kids. And then over the long term, what we see is that the body's responsiveness to the oxygen and carbon dioxide level issues kind of decreases over time. So initially, when the oxygen and carbon dioxide levels start to be abnormal, the body, there's a lot of arousals and very poor sleep quality. But over time, as the neuromuscular disease progresses, sometimes the brain and the chemoreceptors are less sensitive to these changes, and the patient stops having the arousals that they should have in response to these abnormal gas exchange. And so then they get better sleep quality, but we see a lot of issues with the quality of their breathing, again, restoring the normal oxygen and carbon dioxide levels. So symptoms of sleep disturbance, when I'm seeing a patient in clinic, these are things that I like to ask about. I ask every parent, does your child snore? And I want to know, if they do snore, how loud is it? Could you hear them from outside the bedroom? Can you hear them from down the hall? And I want to know, how often is it? Are they snoring every single night, or do they only snore if they're sick or their allergies flare or something? Very common for kids to snore when they're sick, because, you know, they get congested and mucousy in their nose, and so that contributes to snoring. But if they're snoring on a regular basis, even when they're not sick, then I start to worry more about sleep apnea and issues with oxygen and carbon dioxide at night. Excessive daytime sleepiness certainly is a suggestion of poor sleep quality at night. Now, the most common cause of excessive daytime sleepiness in kids is just not getting enough sleep at night. But if it seems that they are getting enough sleep at night and still tired during the day, that kind of raises my antenna a little bit as well. Daytime fatigue or tiredness, again, suggestive of poor sleep quality. Any patient that complains of trouble breathing when they lay down flat, especially flat on their back, is very suggestive of breathing difficulty in sleep. And during the day, they may have trouble with school. They may have trouble focusing, paying attention to their homework. Sometimes we see kids that are actually hyperactive, and this is all from sleep disturbance, not getting good sleep quality at night. Some kids also have mood disturbances. And any parent, neuromuscular disease or not, you know that when children are tired, they're often very difficult. They're very irritable. And then less likely, but one of the things we do look for is if the oxygen levels are low enough, it can cause seizures. So if the child is having seizures in sleep, that certainly would make me worry about some sort of sleep-related breathing disorder. On physical exam, these are the certain physical signs that can suggest higher likelihood of obstructive sleep apnea. So large tonsils and adenoids are known to contribute to obstructive sleep apnea, and that's just because tonsils sit right at the back of the throat. So if they're enlarged, they can obstruct or block off the airflow back there, and that's what's showing in this picture on top here. This is the child's tonsils, the left and right tonsil. As you can see, they are huge and basically blocking off the entire back of the throat. This is the uvula that hangs down. This is what we call kissing tonsils. They're so large, they're touching in the back of the throat. So it's not hard to imagine how that would cause obstructive sleep apnea at night. Adenoids sit kind of behind the nose. Can't see them from the outside, but similarly, when they're big, they obstruct airflow through the back of the nose. Mouth breathing is suggestive of some sort of nasal obstruction. So certainly if your nose is completely blocked off, the child will compensate for that by breathing with their mouth open when they sleep. Nasal sounding speech can again suggest some nasal obstruction. A large tongue or a crowded airway can suggest sleep disorder breathing or obstructive sleep apnea. This bottom image here is showing what we call Malampati scores. And this is just a marker of how open their airway is. And there's nothing anybody can do about this. This is just how God made you. But a Mallampati class 1, if you ever hear a doctor refer to a Mallampati score, Mallampati class 1 means a nice and open airway. Mallampati 4 means a very crowded airway, that when the child opens their mouth and protrudes their tongue, that you can't see anything except the roof of their mouth. You don't see the uvula at all, which is the thing that hangs down. You don't really see the tonsils at all because the view is completely obstructed. And patients who have obstructive sleep apnea can, over time, if it goes untreated, they can develop high blood pressure and they can also develop heart failure. So if those things are present, it makes me want to order a sleep study in these kids. So the guidelines for when do we need to order a sleep study in kids with neuromuscular disease? The suggestion is, of course, if they have any of the signs or symptoms we talked about, if they're snoring on a regular basis, if they're tired during the day, if they're having trouble focusing or paying attention in school, this would be a good reason to get a sleep study in a child with neuromuscular disease. And then with regards to their pulmonary function tests, there are certain parameters that if their numbers are low enough, we say, yeah, we should probably go ahead and get a sleep study in this child, because even if they're not snoring, their respiratory muscles may be so weak that we would worry about their ability to move oxygen in and carbon dioxide out when they sleep at night. So this is suggested for patients with an FVC below 40% of predicted. And remember, we talked about these predicted values in all kids, which are based on age and gender and height. FVC stands for forced vital capacity. All that means is the total amount of air a child blows out. And in this example, the predicted value is 2.96 liters. This child blew out 2.4 liters, total amount of air they blew out, and that was 81% of the predicted value, which is pretty darn good. But if this number were to drop below 40% of the predicted value, that's when I'm going to start thinking about getting a sleep study in this child, even if they have no signs or symptoms that we talked about on the previous slides. If their carbon dioxide level is above 45 when they're awake, it's likely to be even higher than that when they're asleep. In general, anything below 50 we would consider normal, but if it's above 45 when they're awake, it's a pretty good chance that it's rising above 50 when they sleep. And so if their awake carbon dioxide level is above 45, I would want to get a sleep study. You can see this child's awake carbon dioxide level is 31, so that's darn good. Same thing, our oxygen levels below 95 when you're awake is a higher risk of them dropping to a dangerously low level when they're asleep. So that's another time I would think about getting a sleep study. And then in teenagers and adults, they can use an absolute FVC below 1.25 liters. We don't really use absolute values in younger kids. We're looking more at the percent of the predicted values. But in adolescents and adults, we could look at the actual liter flow as opposed to the percent predicted. This is, in general, what a sleep study hookup looks like. And these are all of the different things we monitor on the sleep study. We put these little stickers on their scalp, so the tech will kind of separate the hair and put stickers on the scalp. And we are looking at their brain waves there, mainly for the purposes of telling us what stage of sleep they're in. So when the brain waves can tell us when they're asleep or awake, and also what stage of sleep they're in. We monitor, of course, the oxygen and carbon dioxide levels. We monitor airflow through the nose. So that's what these little prongs here in the child's nose, these are not delivering oxygen. These are measuring airflow to sense if he has an obstruction to airflow or a pause in his breathing. We have these soft little belts that go on the chest and abdomen. That's looking at their work of breathing, if they're having to take really huge deep breaths to achieve normal oxygen and carbon dioxide levels, or if they have decreased abdominal and chest wall movement because of their weakness. We can pick that up on the abdominal and chest wall belts. We have these tiny little leads on the outside of their eyes that are sensing eye movements, and that helps us know when they go into the certain stage of sleep called REM sleep, or rapid eye movement sleep, because the eyes move very fast in REM sleep, and it helps us identify that stage. There's a snore sensor, which at least half the time picks up the parent who's sleeping at the bedside. So sometimes the snore sensor is not very reliable, because sometimes it's not the child, but the parent who's sleeping next to the child. We have a single lead EKG that's monitoring their heart rate and heart rhythm. We monitor leg movements, looking for things like restless leg syndrome, that kind of thing. And then we also video them. So this is generally what what the hookup looks like for the sleep study. And I always explain to kids, even though this looks very intimidating, there's no needles involved, there's nothing that's painful to them. It's just a lot of stickers and wires and monitors everywhere to be connected to. And some parents will ask me, well, do you put my kid to sleep? Are you going to give him medicine to make him sleep? And the answer is, of course, no. I don't want to sedate the child because that can alter their breathing pattern. But almost all kids sleep eventually in the sleep lab. Sometimes it takes them a little while to fall asleep, but the need to sleep is a powerful one. And it's eventually they usually fall asleep even connected to all this stuff. This is like way more granular than anybody needs to know unless you're a sleep doctor, but I thought I would pull it just to show you what obstructive sleep apnea looks like on a sleep study. This is 60 seconds worth of data from a sleep study. And for the sake of time and boredom, I'm not going to go through every single line here and what they mean, but hopefully y'all can see my mouse here. These two blue lines are the airflow sensors. Okay, and the light blue lines below it are the chest and abdominal wall belts, the chest and abdominal movements. And the chest and abdomen should rise together and should fall together when a child breathes. When we see them moving apart from each other, that's a sign of increased work, what we call increased work of breathing, or paradoxical respirations. That child's working hard to maintain patent airflow. So what we see here is that the two airflow sensors, they just flatline completely for about 12 seconds. And then up here is the oxygen monitor, or the pulse ox, and their pulse oximeter drops from 98 to 94 before it starts to recover. So this is a very classic obstructive apnea on a sleep study. And you can see this little red R in the background means the child is in REM sleep, or rapid eye movement sleep. And that's when obstructive apneas are most likely to occur because we lose muscle tone. So let's talk about ventilatory support. This means things like CPAP and BiPAP that we can use to help them breathe when they sleep at night. And sometimes eventually during the day, some kids, as their neuromuscular disease progresses, use daytime ventilatory support as well. So the goal of non-invasive ventilation, so invasive ventilation just means through a tracheostomy, through a tube in the neck. Non-invasive means through a mask that they wear at night. And most people are familiar with CPAP or BiPAP because a lot of people have a mom or a grandma or something that has sleep apnea and wears BiPAP to sleep or something. But the goals in patients with neuromuscular disease are to prolong their survival by improving their gas exchange, so maintaining normal oxygen and carbon dioxide levels as long as possible. And there's actually very good data that use of BiPAP with sleep can prolong survival in these patients. We want to relieve their symptoms. If they have shortness of breath symptomatically, we want, of course, to relieve that so they can sleep better. We want to allow for the normal gas exchange, oxygen in and carbon dioxide out. We want to treat any obstructive sleep apnea that may be there. Improve their daytime function through improved sleep quality. So as we all know, sleep affects everything. It affects your ability to perform in school, to engage in healthy relationships, for older people to perform well at your job. So we want to improve their daytime function through improved sleep quality. We want to prevent the development of heart failure that can happen if they have untreated sleep apnea or abnormal oxygen and carbon dioxide levels for many, many years over time. They can develop heart failure, so we want to prevent that. And we also want to support their growth and development. So we know that kids who don't breathe well, they just tend to not grow well. You know, normal oxygen levels are necessary for everything. All of your organs, you know, your brain, your kidneys, your liver, all of your heart, of course, all need oxygen to function properly. So by maintaining normal gas exchange, we support their growth and development. There are some studies to show also that using non-invasive ventilation at night can actually help with daytime carbon dioxide levels. So even kids who have abnormally high carbon dioxide levels during the day, if they're not using their machine during the day, but they're using it at night, at the beginning, it can help with the daytime carbon dioxide levels as well. And then eventually, many years later, over the long term, it may not be as effective anymore, and then they need non-invasive ventilation during the day also. But initially, just nighttime use is enough. And the use of non-invasive ventilation has been shown in multiple studies to reduce frequency of hospitalization, so reduce how often these kids have to come in the hospital with respiratory illnesses and improve survival. There are two main modes of non-invasive ventilation that I use in patients with neuromuscular disease, I would say the most common is probably BiPAP, and BiPAP stands for bilevel positive airway pressure. So what this is, we set an inspiratory pressure called an IPAP and an expiratory pressure called an EPAP. So the machine is supposed to sense the patient's breathing, and when the child breathes in, it ramps the pressure up to the IPAP or the inspiratory pressure, and when the child breathes out, the pressure kind of decreases down to the EPAP. It also allows us to set a backup rate, which means if the machine senses that the child is not breathing for however many seconds we tell it, then it has the ability to give the child a breath. So if the machine senses this child hasn't taken a breath for 6 seconds or 10 seconds or whatever we set, then it will deliver a breath by ramping the pressure up to the IPAP. So you may see the settings written this way. If your child is on BiPAP, you may see the doctor order it like this, where it'll say, for example, 14/6. This means the inspiratory pressure is 14, the expiratory pressure is 6, and the backup rate is 12. That means we want the child to get at least 12 breaths per minute. And if the child's breathing less than that, then it'll go ahead, the backup rate will kick in. The other type of non-invasive ventilation I order pretty frequently in kids with neuromuscular disease is called AVAPS. This stands for Average Volume Assured Pressure Support. It acts very similarly to BiPAP, but the difference here is that we can set a goal tidal volume with each breath. So with BiPAP, you set the pressure, and the pressure ramps up to the IPAP or the inspiratory pressure. And however much volume of air the child gets with that breath, that's just how much they get. There's no controlling the volume. It's just however much they can get with that much pressure. With AVAPs, we can set a goal volume. So I can say, based on this child's age and size and weight, I want them to get, for example, 300 milliliters of air with each breath. And I can tell the machine that I want the child to get X number of milliliters of air in each breath. And the machine can adjust the pressure within the range that we set as needed to guarantee the volume, the goal volume that we want them to get. So this graphic is kind of advanced and took me a while to understand it, but we can set an inspiratory pressure minimum and an inspiratory pressure maximum. So for every breath, the machine's going to deliver somewhere within this range to achieve the goal volume. So what we see in the bottom part here is with the first breath, the kid achieves their goal volume. Great. The next breath, for whatever reason, they don't. Maybe they're not working as hard to breathe anymore. Their respiratory effort decreases. They did not get their goal tidal volume. So the machine senses that, and it's going to gradually ramp that inspiratory pressure up, staying within the range of the dotted lines here, but it's ramping that inspiratory pressure up until the kid gets back to their goal tidal volume. And that's a little advanced, but these are just kind of a brief summary of the two different types of ventilation that I use most commonly in kids with neuromuscular disease, BiPAP and AVAPs. There are a million different masks on the market for BiPAP and AVAPs, and these are only a few of them. And I show this just to demonstrate a sample, but there are many, many more than this. There are general categories. These ones that go just over the nose, these three on the left that go just over the nose, we would refer to as a nasal mask. Then the one that goes over the nose and mouth like this, we would refer to as a full face mask. There are some that sit up just kind of in the nose, these soft little cushions like this in the middle. This is called a nasal pillows mask. So this lady on the bottom has a nasal pillows mask. This man has a nasal pillows mask as well. You can see there are a lot of different headgears out there on the market. This one goes up just around the ears, so it doesn't have to strap behind the head like this one straps behind the head. This is what we would call a hybrid nasal pillows full face mask. So it has the nasal pillows and it also goes around the patient's mouth. And this child has a whole face mask, or sometimes they call this a scuba mask. And one mask is not better than the other. It's really whatever the child finds most comfortable or most tolerable. I do worry about in kids who are too weak to remove the mask themselves. I prefer to not cover the mouth. And the reason is if they were to have, for example, if a kid gets a stomach bug or they've been vomiting or retching, if they were to need to throw up and they threw up into the mask covering their mouth, there's a risk of that air pressure shoves that vomit back down into their lungs and can cause an aspiration pneumonia. So For that reason, in kids who are very weak, I prefer to use nasal masks because it reduces that risk of aspiration should they need to throw up. And I always tell parents, if your child is on a full face mask that covers the mouth and they have been sick with a stomach bug or something, it's much safer to just leave the BiPAP or the ABAPs off that night. Okay, I think I just have 2 more slides showing a couple of interfaces. This is a teenager with Duchenne who is needing daytime ventilatory support. So he uses this day and night, and you can see they have this whole setup where the tubing goes up and over the head, down behind the wheelchair, and then the vent sits on a hook at the back of the wheelchair. But this allows his range of sight to be clear. He can still talk and engage with his environment because he has just the nasal interface. And this is also another patient with Duchenne muscular dystrophy, and he's using something called a zipper valve, which we use often during the day. This would not be useful at night because this requires patient interaction and cooperation. So it wouldn't work during sleep, but during the day, this is just a little valve that you can see is set at an angle so he can reach it easily with his mouth. And then the tubing goes back behind the wheelchair and the vent sits on the wheelchair. And anytime he feels short of breath or feels like he needs a breath, he can just kind of lean and suck in a little, and the machine senses that he's sucking in and will deliver a breath to help expand the lungs. The complications of non-invasive ventilation are, honestly, they're relatively few. It's very well tolerated. It's not, it's not medicine. It's not even oxygen. It's just the same air that you and I are breathing right now, just concentrated at a higher flow rate to help open the lungs and expand the airways. Some of the complications we do worry about, specifically in neuromuscular disease, we worry about inadequate triggering because, I mentioned the machine will sense when the patient is trying to breathe in and ramp that pressure up. And when they breathe out, it ramps the pressure down. But if the child is very weak and is not able to really generate much inspiratory pressure, the machine may not even recognize that that child's trying to take a breath in and support that child's breath by instilling the air. So the trigger is the patient's ability to take at least enough of an inspiratory pressure that the machine at least recognizes that they're trying to breathe in. An adequate mask fit is very necessary, of course, to maintain adequate support. So if the mask doesn't fit properly and air is leaking out around the side of the mask, it can irritate the eyes and be very uncomfortable to the patient, in addition to just not supporting them adequately, because of course we need the air to get delivered down to the airways, down to the lungs for it to do its job. Some patients will complain of this feeling of bloating because some of the air goes to the stomach as opposed to just to the lungs. Some of it goes down to the stomach as well, and this sensation of swallowing air. I haven't heard this complaint much, but it does happen. Skin irritation can happen from the mask. There are a lot of different liners and protective things that we can put on the skin to help prevent skin breakdown, but that's something we see occasionally, especially in kids who are really good about wearing their mask all night, every night. They can get some skin irritation. You can get orthodontic problems in kids whose jaw and mouth is still growing and developing. A lot of times the nasal masks sit right here on the upper teeth, and so the pressure from that mask can kind of prevent the jaw and the teeth from growing and developing properly. And kids who start using these machines at a very young age can kind of develop a flat mid-face from its use, because the pressure from the mask itself, if they're starting to use it at age 1 or 2 and they use it every single night for 12 sometimes hours a night, young kids sleep a lot, right? So the pressure from the mask over the long term can impair the face from growing properly, and that's what has happened with this child here. You can see everything is very flat through the middle of the face. In summary, children with neuromuscular disease experience a predictable progressive weakness of the respiratory muscles that can lead to impaired cough strength, difficulty clearing mucus from their lungs, swallowing difficulty or aspiration. They have a higher risk of atelectasis and pneumonia, and they eventually will need nighttime and then sometimes daytime support for their breathing, what we call hypoventilation. Early intervention has been shown to prevent complications and prolong survival. So again, my goal is to start these therapies before kids are having problems. We want to see them on a regular basis in the office, monitor their lung function, and start the intervention before they're having complications. If there is evidence of hypoventilation or other sleep disordered breathing, Then we start with ventilatory support at night, and eventually they may need it during the day. And coordinated multidisciplinary care is really important, I think, to improve their care and quality of life. So I try to stay in touch with these kids' neurologists and their cardiologists, and sometimes they have GI doctors and their nutritionists, and I want to make sure we're all on the same page about the treatment plan and the best care for these kids. This is a list of my sources, and I'm gonna stop sharing my screen and see if anybody has any questions or comments.
Well, thank you so much, Dr. Carwell, for that amazing presentation. And thank you again for participating today. And thank you for all that you do for the neuromuscular community. I do see that there is one question in the chat box. So I'm just going to go ahead and read that out loud right now. We have a question of, can melatonin be used on the sleep study?
Oh, good question. And yes, this is something we do encourage sometimes. Melatonin does not, should not, and it has not been shown in studies to affect a patient's breathing. So I don't want to use a sedating medicine that's going to affect what we see with their oxygen and carbon dioxide. But melatonin is totally fine. Depending on the age of the child, we recommend in a young kid, maybe 1 milligram, in a school age child, 3 milligrams, and an adolescent, no more than 10 milligrams. But melatonin is a perfectly reasonable option to help your child get to sleep in the sleep study. Great question.
Awesome, thank you. And then I'm just gonna wait a few more moments, see if there's any other questions that come up in the Q&A box.
Sure.
And if not, then we will conclude.
Thank you so much for having me.
All righty, well, thank you so much for your participation in this event, and thank you for being our last speaker to close it all out. Again, we really appreciate all you do for the neuromuscular community, and thank you again for showing up today and presenting amazing information. So thank you so much.
You're very welcome. Thank you. Bye.
All right, so this concludes our seminar for today. I want to thank all our presenters for their time today and our supporter, Amicus Therapeutics. And thank you to you for all taking the time to join us today. We hope that you found this information very informative and helpful. And finally, I want to remind everyone that, again, we did record this seminar and it will be posted to our website at mda.org in a few weeks. Don't forget to fill out a survey regarding what you heard today. I will be emailing a brief survey of what you thought of the seminar, but if you would like to take the survey now, you can simply click on the QR code with your smart device camera. So if you have an iPhone, you can take a picture of this QR code and the survey will show up and show you to the site. So again, thank you so much for joining us today for this seminar, and I hope you have a great rest of your day.